So good afternoon, everybody, and welcome to this meeting, which is actually our 12th meeting of the West Yorkshire Harrogate Health and Care Partnership Board. We've got a pretty full agenda today, so I'll not summarise everything on it, but particular highlights include a normal update from Rob, the partnership's CEO designate, reports on health inequalities and the Connected Inclusion Week, the publication of the West Yorkshire Suicide Prevention Strategy and Action Plan, and a number of other updates, including the Green Plan, People's Plan, and a 5-year strategy. We're continuing to meet through Teams and to make the meeting available both by live stream but also as a recording afterwards. We'll have a short break at some point during the meeting. So if I can remind people, as always, if people can mute the microphone, sorry, when you're not presenting or speaking, but do have your cameras on when you're presenting and speaking, of course. And people use either the raise hand function or the chat function if you want to come in on anything. Before we move on to the agenda, I'm just going to update on some of the appointments that take place to the Integrated Care Board following the recruitment process that's gone on since the last meeting. And this includes, I won't give the full summaries I've been given of people, perhaps we can share that afterwards, but to welcome Beverly Geary, who's been appointed as Designate Director of Nursing, Jonathan Webb, Designate Director of Finance, Dr. James Thomas as the Designate Medical Director, and Kate Sims as the Designate Director of People. And also to note, congratulations to Mark Brooks, who's now been appointed as the new Chief Executive of the South West Yorkshire Partnership NHS Foundation Trust, having been the interim in that role for a while. Congratulations, and this is where I come unstuck by not doing my homework properly. So I do apologise, but congratulations to Faluka Ajep. I'm going to ask Rob to make sure I don't get Fajuka's name wrong. Sorry, Rob or Ian, can you help me with this?
Well, it's Faluka Ajay. Yeah, so
I do apologise. The new CEO of Airedale NHS Trust, and finally to Steve Russell, who'll be joining NHS England on secondment as the National Director for COVID-19 and flu vaccinations. And while Steve's away on that, Jonathan Coulter will be acting Chief Executive. So I think that covers all the announcements and changes we have. So quite an exciting time in terms of new roles and changes. The first item on the agenda is questions and public deputations. Steve, can I just ask you to explain where we are with these and what we have?
Yes, Chair, we've had one question from a member of the public, but it was in connection with a personal healthcare issue, so we forwarded that on to the relevant CCG for investigation and response.
Thanks very much. So moving straight on to remind colleagues of to declare any specific interests that you may have, but also to remind people who may be observing, of course, we have a standing register of declarations of interest based on all our individual declarations to our own organisations. And to move on to take the minutes of the last meeting held on the 7th of December and the associated action log. Just checking if anybody has any concerns of accuracy of the minutes. Not seeing anybody, so could I ask Ian to provide us, Ian Holmes, to provide us with an update on the action log. Ian.
Thanks very much, Councillor Swift. And just to say that we've had a few minor drafting points from Andrew Gold. They're not material to the decisions that we took or the actions, but it's really helpful to have those. So we'll correct for those and send out the revised version. So thanks very much to Andrew for that. In terms of the open actions, I think there's 7. So the first one related to the conversation that we had last time around operational pressures. and we agreed that we'd bring an update on the development of operational plans for 22-23 back to this meeting. So Anthony Keeley will be leading that discussion. It's on the agenda for today under item 10.22. On the item around the local Health Watch Insight report, we agreed, I think last time, that we'd have 6 monthly updates from Health Watch. The last one was December, so the next one will be June. We had a good conversation last time about the draft constitution. You'll remember that the engagement period for that closed mid-January, so we committed to bring back a revised draft that reflected the comments that we'd had. So we'll be doing that today, as well as a draft version of the governance handbook. On the people plan, we agreed to bring back a delivery plan that sat sort of underneath and underpinned the people plan, and again that's on the agenda for today under 13.22. And then under any of the business, we had a conversation about the work that we need to do to refresh our 5-year strategy, and that's on the agenda for item 14.22 today. I think there's a couple more over the page, Lauren. Yeah, so the next one was around measurement and delivery of our 10 big ambitions, and again we've put that under item 14.22 on the strategy refresh, and then the final one is the standing item that we've got relating to the race quality network, where we bring progress back against the action plan quarterly, and that's the first item on the agenda for today. And then the closed action is the action that we had to bring the constitution back to the meeting that we had last time in December, so we've closed that one now.
Okay, thank you very much, Ian. Are there any questions or comments for Ian on that one? Okay, that's great. I'm not seeing anybody. So I'll move us straight on then to item 5, which is an update from Rob Webster, our CEO designate. Rob, over to you.
Thanks, Chair. Hello, everybody. It's good to see you all, and welcome to the 12th meeting of the Partnership Board. It's really good to see the collective leadership on shore here today, and I think there's a theme I think running through all of today, which is about our collective leadership and the work that we're doing. Can I just add my congratulations to the people Councillor Swift mentioned at the beginning in terms of the appointments that we've been making. I think what I'm particularly pleased with, and if we could add a couple of people to that list, I know Marie Burnham's on, I'm not sure she was confirmed as the new chair of Swift when we last met, so welcome to Marie, and Salma Yasmin, who's Deputy Chief Executive of Swift, now that the changes have been confirmed in that organisation. I think the thing that I welcome about the appointments that we're making is that we've got a mixture of people who've been part of our system and people who haven't, and people from a diverse sort of range of backgrounds. So we know that diversity of thought leads to, you know, improvements in delivery, and that's what we're seeing. So what you might not have picked up in the names of the 4 ICB directors, for example, is that, you know, Jonathan and James working in the system, but Kate is coming from West Yorkshire Police, where she's doing a sterling piece of work, I think, for their workforce strategy, workforce improvements, particularly around diversity. And Bev Geary is coming from Humber Coast and Vale from Hull Teaching Hospitals Trust. So we're getting that sense of, you know, diverse leadership and new people refreshing the already great leadership that's onshore across the system. So I just wanted to start there, because I think what we're seeing is, if you look at my report, which, apologies for its length, I think I'll just stick to the key points, is that even in the space of 3 months, things occur that we have to deal with immediately. So just to remind you, since we last met at the beginning of December, you know, we dealt with the highest ever levels of COVID infection with the Omicron surge, which came upon us very, very quickly. We've had to then deal with the consequential impact on staff absence and maintain services during winter, when urgent pressures for health and care were severe. We were then asked to deliver the vaccination booster programme a month early, with immediate effect in the run up to Christmas, so that everybody was offered a vaccine booster, and we delivered that through our collective efforts and fantastic work from all parties, whether that's volunteers, the third sector, primary care, our hospitals, our hubs, or the trusted voices in community maintaining confidence in the vaccine. We were then asked to prepare for the consequence of the Omicron surge. We had a trebling of the number of people in hospital within 2 weeks. And if that continued, we felt that, or knew that the predictions would be pretty dire for the population and for the system. And to help with that, we were asked to reduce the number of people who had no right reason to reside in hospital by 30%, which we did. We achieved that by the end of January. And we were asked to erect a temporary structure at St James's Hospital, and huge credit to Julian's team and the estates folk over there for getting that ready and up and running as a surge hub in case things got incredibly difficult. So we were asked to do that, and we delivered that too. During that period, we supported retention of staff in domiciliary care through transfer of resources to make sure that they were paid national living wage at least to maintain in the run up to Christmas the retention of staff for whom there's a sense of belonging and worth, plus basic pay is the thing that will keep them in jobs in our sector. So we did all of those things during a period when waiting lists unfortunately continued to grow, and pressure on our services was extreme, particularly in things like the Yorkshire Ambulance Service. But we prioritised work to such an extent that we were able to maintain the 2-week cancer referral targets, and we continue to make substantial progress on things like the race equality review. And all of that's reflected, I think, in the report, and it's reflected in the papers for today and on the agenda. Now the context that all that's set in is changing, but it's still one where we have to continue to pursue our objectives and our aims and our strategy whilst dealing with changes in context. So this week we're trying to really follow what the consequences of the removal of most of the remaining protections for the public around COVID-19 will be, and thinking about what our preparations might be as a system for our staff and the services that we all rely on. So that's one bit of context that we're dealing with. Another is, the reinforcement of why we talk about race at every meeting, and it's the first issue that we talk about through 2 pieces of work. I think it's a bit of a typo in the paper, but the first is that the Race and Health Observatory put all the evidence together from across the country of racial disparities for our staff and for service users. And you may have seen the sort of coverage of that in the media, which was very high profile. And the second was the British Medical Journal did a piece of work on the racism experienced by doctors in the NHS. Now we followed up, we've obviously got our race equality work, and we've got a report on that today. And we followed up the BMJ article where we wrote to everybody in every system and asked them to pass on to all the doctors if they're facing any issues and don't believe that they're being addressed. They've got the support of our collective leadership to raise those issues and get them addressed. But those things that keep appearing about the impact of racism, overt racism and structural racism in elements of our society continue to remind us of the importance of this agenda. We're also in the context where the government is making additional funds available for the rest of the year. We're seeing that in some of the capital programmes. So again, our colleagues in our hospitals are looking at how we prioritise additional capital to make sure that we can protect certain sites so that they're always available for surgery to tackle waiting backlogs. And we're already making progress in places like Wharfdale and Chapel Allerton on that, and expect to hopefully make progress on places like St Luke's in Bradford and in Dewsbury and elsewhere. So that additional money is welcome, and this is in the context again of systems then being required, our system for example, being required to prioritise that resource and continue with practical application of joined up care in light of the Act that's going through Parliament. And the Act is back in Parliament, isn't it, at the moment? There are some amendments which may pass to the bill, which are about mental health representation on boards. We've already got that here, about the explicit openness around mental health investments. We've already got that here, and similar sorts of amendments. What hasn't yet passed is the focus on the workforce and potentially a requirement for government to have a costed workforce plan. Again, that's on our agenda, isn't it? And something, irrespective of what government does, we need to move on with. So we've got all of that change going on, and since we last met, 2 new white papers which complement that. The integration white paper, which really speaks to what goes on in all of our places. And that white paper, again, I think, highly consistent with what we're doing here. So we've already said as a partnership, we want most of the work to get done in places, the resources to be allocated to places, a person to be able to receive those resources, to be accountable to a committee locally for delivering improved outcomes, which achieve the aims of the health and wellbeing strategy for that place and contribute to the health and wellbeing strategy for the system. That's set out in the governance papers later on, and in the governance handbook. You can see those. And that white paper, you know, with its plans to have a smaller number of outcomes that were measured on nationally, a better approach to regulation, so we regulate systems, not organisations, and you know, those place-based arrangements in place, feels like a bit of sort of tidying up, which we would very much welcome. And then the levelling up white paper makes some steps towards looking at the extreme inequalities that are faced in parts of the country. And I wrote recently in the local government journal, the MJ, about inequalities and levelling up and the opportunities that there are through our arrangements to really make progress on that. But it requires resources, and it requires commitment, and it requires the right kind of approach. And I cited in that 2 reports which just describe the scale of the challenge ahead. The Northern Health Science Alliance reports into 1 year from COVID, and Child of the North, and the discrepancies are stark. So what we're now doing with the leadership that we've got, and in this context, and on the back of what we've just been through and what we've been building on for the last 5 years, is planning for the next phase. And again, you'll see that on the agenda. We're talking about how we do the planning we're required to do in the NHS, how councils are setting their budgets for the year, thinking about the council tax and social care precepts, and raising those to get sufficient resource to pay the staff and pay for the workforce to deliver the care that's required. And it feels like with the planning for the year ahead and the strategy for the next 3 to 5 years ahead, we'll continue to focus on our 10 big ambitions. And it's really good to see the suicide prevention strategy on the agenda today, and the sustainability strategies. There's 2 of those 10. We'll continue to focus on those. There's definitely going to be a focus on waiting, isn't there? And we'll need to think about the enabling strategies around money, people, and digital. So I think that's all I'll say by way of introduction, apart from to ask one thing of everybody, and that's if you look at the race equality update that we're going to go into, and if you look at the Connection on Inclusion reports, you can see we're making huge progress. If you look at the evidence from the Race and Health Observatory and the British Medical Journal, the BMA's piece of work, you can see that this is still in the context of our staff, our colleagues facing overt racism. What we all need to do as signatories to the anti-racism movement is think about what personal steps we can take to show allyship, show leadership, or to lead our organisations to ensure that we address all of this over time, because it's going to take time. So the thing I'd ask is for us all to think about what we're going to do personally as part of the anti-racism movement to ensure that that is the case. I know many of you are working very visibly in this field already. And one of the small things you might want to do is just to make sure your race equality networks have the capacity and the backfill for the people in them to do their work. So that's all I was going to say, Councillor Swift. The report substantially includes a lot of detail. Happy to pick up any points that anybody has.
Thank you very much, Rob. So there's an awful lot in there and in the written report. So questions and comments. I go first to Councillor Venner. Fiona, to you.
Hi, thank you, Chair. Thank you for your report, Rob. Very comprehensive as always. I just had a comment and a question. So my comment was on the section on primary care, which references, you know, the great, you know, the pressure that primary care are under. One of the things we've been discussing in Leeds at the primary care commissioning committee, and also it came up in the Mental Health Partnership Board, is a real discrepancy between how hard primary care are working, the amount of appointments that are being offered, you know, the fact that GPs are generally offering more appointments than pre-pandemic levels, but a real discrepancy between this and what the public think is happening. It was really apparent in the Mental Health Partnership Board, where Leeds Involving People presented a survey they'd done of their members, which was just entirely about, you know, not being able to get appointments, and obviously that's people's lived experience. We need to respect that, but it does feel like just a real mismatch between public perception of GPs availability and what they're actually doing. And I think the concerning aspect of that is it's leading to some of the really chronic unacceptable abuse and threatening behaviour that both GPs and their staff are facing, because there's this kind of public perception that they're not working hard enough, and obviously that's not really helped by, you know, the government constantly bashing GPs. But that was just a comment really, that I think that's a really massive comms issue that we're facing as a system. And then my question was really about the cost of living crisis, which is coming up, I'd say, at least once a day in meetings I attend, because you know, I've got political responsibility for both adults and children's social care, so it's just coming up everywhere really about the pressure families are going to be under. And I just wondered really what you envisaged the impact of that being, both on obviously on our system really, in terms of both the impact on patients, but also obviously as organisations we're all going to be facing massive increased costs. Thank you.
Thanks, Councillor. So on the first point, you know, both things can be true, and are true, that GPs are working incredibly hard and delivering more care, and some people in our populations feel that they're not able to access their GP. They don't feel that they're supported well by their GP, or they feel frustrated about the arrangements for accessing their GP. That was clear before the pandemic, and was one of the reasons why things like you know, mobile solutions and digital solutions to access to GP for some people was a policy priority, which has now been accelerated through the pandemic. So what we've been trying to do to address this is trying to make sure that people have the facts, and there's some good work that Karen and the team did around, you know, an explainer on why our GP is working differently, what's happening, and what should you expect. And then we've been co-producing with GPs, their teams and communities, some particular work which is about to launch around the violence and aggression against staff. Karen, I don't know if you want to just briefly talk about that campaign just for a second before I address the cost of living issue.
Yeah, of course. Thank you, Rob. And really tricky balance, isn't it? I think, Councillor Vernon, what you were just saying there, between obviously levels of frustration from the public when they're hanging on the call for a long time, whilst absolutely recognising the pressure that GP receptionists and pharmacists are under as well. But we've done a little bit of insight with patients, and we've done some insight with primary care staff and pharmacists about the level of abuse that they've been experiencing. And your heart just sinks, you know, cars are getting scratched and pharmacists are getting spat at. There's death threats going to GPs. So we have to do something about that, don't we? And so what we're doing is building from insight. We'll be launching a campaign in the middle of March, trying to get that balance, because if staff leave because they feel abuse or they can't live with the anxiety or stress at work anymore, that doesn't help any of us. Whilst recognising that it can be extremely frustrating when you're hanging on a call for care for a child or somebody, or your elderly relative. So we'll be launching that in the middle of March, and I have been sending some updates, but I'll make sure you've all got an update ahead of that going live.
Thanks, Karen. This is one I think where a bit of insight and a bit of campaigning matched with local leadership, really. This is about trusted voices in places, saying the right sort of things, I guess. Julian, I don't know if you wanted to come in on this point, or if you want me to move on to the cost of living and then come in.
Well, Rob, sorry, I did just want to come in to say it's important to know that colleagues in primary care have the full support of the healthcare systems at place level, and indeed the way we work as acute trusts with our primary care colleagues. Certainly our experience has been, through some of the really tough periods we've had, GPs have come into our hospitals and have helped support the effective management, triage, discharge of patients, and therefore I think we all feel strongly about the kind of unwarranted vilification that can appear in some quarters of the media and public behaviours. So I think it's just worth saying that, and particularly, Rob, given the emphasis you placed in your opening remarks on tackling waiting, and certainly the work that we're doing across Wyatt and the session we had yesterday with you and other colleagues from the region about how we're tackling our longest waiters, and the point you made about primary care colleagues identifying waiting as a chronic condition is something that we're all motivated to tackle fully, and I think the plans that we've got are good. The points you made about the elective hubs are there. We hope to see our significant share of resource from that fund into West Yorkshire to support that work and continue the good work we're doing to try and shorten waits as far as we can for patients. So I'll stop there. Thanks, Rob.
Well, thanks, Julian. So, Councillor Swift, I can see a few hands going up, which might be around this topic. I don't know if you want to take over the chairing of this bit.
Yeah. Yes. Yeah. Let's stick to the primary care one for a minute, because I think they probably both are. So over comes Halid next.
Thanks, Councillor Swift. I think the thing around what's happening in general practice, I think we need to see what we can do at place level and what we can do at the West Yorkshire as a region level. At place level, we have had patient engagement events where we have presented to them the new ways of working and how we are making sure that patients' needs are met appropriately, and people have got perception that probably the face-to-face appointments are not being offered, but we are telling them how face-to-face appointments are working at the moment, and I think the issue with primary care is a one-stop shop and it's it's accessible to anybody and everybody, and wherever the patient has got problem in the healthcare system, they come back to general practice, and general practice becomes their port of call and then solution for everything, and that is a good thing. But at the same time, it also makes us vulnerable to more scrutiny by the public, and we need to make sure that we keep on meeting their demands. Our demand has gone way above we can manage in primary care, but at the same time we also increased our capacity to a big extent. Staff, we are facing staff shortages. Staff is leaving practices, and the stress they have to go through. They have to go through the COVID period, the change, and the vaccination, and then the patient responses is something which creates a lot of upset in the system. but at the same time, we need to see how we are managing it locally. Locally, we are managing it by engaging with public representatives. I was in the scrutiny committee in February, and then we did all the presentation, how the demand has gone up, how we have increased capacity, how many more appointments we have created, and how how many of them are face-to-face, how many of them are virtual appointments. But at the same time, we need to manage media. In my opinion, if we don't manage media, public opinion is going to be negative about it. And when we talk to media, they say, oh, we don't get any positive news from you. So we publish what we get from people. So that's what we need to get our engagement with media more effective, in my opinion. Thank you very much.
Thank you. Can I go to Susan next? Susan, Councillor Hinchcliffe.
Thank you. Just again on the GP point, obviously we're grateful for all NHS staff for doing everything they do, and I've been doing during the pandemic. What we can't get away from the fact, though, is there is a massive shortage of GPs in this country, and particularly in disadvantaged areas where they don't get as many applicants to be GPs. And I think we're 6,000 short in the country, are we? And therefore, as a health system in West Yorkshire, I'd like to think we can work with government to get more GPs into the system. Indeed, I would obviously we've been pushing for a number of years now to get a medical school in Bradford that the government has pushed back on again and again. We need more GPs in Bradford district, particularly in our disadvantaged wards, and we do not have enough GPs. And therefore, there is a systemic problem we have, and we need to be on the front foot, I think, in going to government and saying this is what we need to solve this in West Yorkshire. And I'd love us to put a plan together for government to fund, as I said, this is how we resolve the crisis of shortage of GPs in West Yorkshire. And I think that's a piece of work that we should be on the front foot of doing, and then government knows the issues and knows how to resolve it, because we do have the answers here if they'll invest as we want them to do. And I think we should be quite clear with them about what it takes to do that.
Thanks, Susan. Peter Davis. Peter.
Thank you. I want to say something to support what Susan Hinchcliffe has just said, but also as a GP, can I comment on the sheer difficulty of doing general practice in deprived wards? If you think of the deciles of deprivation, and in deprivation we're probably talking about 1, 2 and 3, I reckon the GMS contract that we run on as GPs treats each patient as one ordinary patient. There's a bit of waiting for what's called a Carr-Hill fund to try and put a bit of extra money into the deprived wards. But if I'm honest, if I was working in BD3 or in Mixenden where I was working for a while in Halifax, a patient there should be weighted about 2 or 3 times the amount of work of, dare I say, someone like me who's a middle class person in Halifax, registered at Rosegarth in the nice end of Halifax, and the waiting for deprivation and the sheer amount of how do I describe it? If you look at a 50-year-old man, or if 50-year-old people, say around here, were professional middle class people, we will look 20 years younger than a 50-year-old in Mixenden or a 50-year-old in some of the poorer ends of Bradford. We will mostly have our teeth. They won't have any teeth. Well, they probably won't have teeth. Forgive me, the dentistry is even worse for inequalities than some bits of medicine. As a country, as a system, we need the sheer complexity of the amount of physical medicine, mental health medicine, life difficulty medicine, also, dare I say, the social, what do we call it, the criminal justice side of stuff, where people get themselves into criminal justice trouble. That concatenation of stuff in the poorer deciles of our country, it's a huge problem. The more we can do to get into that, the better. The current way we fund general practice is nowhere near meeting that in any sense, or even recognising it.
Thanks, Peter. Susan, did you want to come back on that? Hands come up again.
Yeah, I wasn't going to get onto the Cahill formula, but Peter's mentioned it, and I absolutely agree that Cahill formula needs scrapping and restarting. If you're a younger person with ill health issues, the Cahill formula completely misses you out of those calculations. So we've got a young population who typically might suffer ill health earlier than more affluent populations, and that there is not reflected in the Cahill formula. We need to change the Cahill formula at national level for it to reflect the issues that we're all facing in West Yorkshire. And until we change the sum, we will never get a different outcome. So that sum needs changing. I'd welcome the medical professionals in the room giving us some assistance in how we change that and propose to government a different way forward. So yes, please, let's scrap the Cahill formula.
Thanks, Susan and Peter, for those contributions. Can I go to Brian McGregor next?
Thank you, Chair. Thank you, Chair. I should declare an interest. I'm Chair of the Yorkshire Regional Council of the BMA, as well as being here as an LMC representative, and I sit on GPC for the BMA. And you're absolutely right, the Cahill formula is not fit for purpose, but we've been trying to get it changed for 10 years at least, if not more, and they're not even listening to the medical professions asking for it to be changed. It does work against inner cities. There's no two ways about it. There's also going to be another national media campaign about resourcing and capacity in general practice that's going to start in mid-March, from jointly funded by the BMA and GPDF, and it will have local flavours as well. There'll be local champions that are going to be appointed. I'll be one of the national spokespersons from the BMA's perspective in regards to that campaign. I don't know the exact details because the first briefing meeting is tomorrow, I'm afraid, but it will actually be about trying to highlight that the huge demand is the problem in general practice, not and it's a lack of capacity. We're about 7,000 GPs down from when they told us we needed 5,000 more. Well, the 5,000 more and 2,000 more down. Any plans we make cannot be predicated on increasing the GP workforce. There is no cavalry waiting over the hill. There is no herd of GPs on a golf course waiting for the right funding level or the right workload level to come in. Our workforce is what our workforce is, and it's not going to change for the next 3 to 5 years as a minimum. I firmly believe that integrating our services, working in close partnership, and as has been mentioned in the chat, it's not just GPs. There's an even bigger retirement hump in practice nurses, and community nurses are really feeling the strain at the moment. And social care is another sector that just isn't getting the right staff into the right areas. So we need to integrate so that we're doing things as efficiently as we can as a unit, as a system going forwards. And that's what's going to get us out of the massive demand, so that we can get people to where they need to be as quickly as possible in the future.
Thanks very much. Reflecting on those, and perhaps something particularly for the council leaders in this conversation to take away. I mean, I appreciate we try to avoid anything in these conversations that could be seen as being excessively political, but you know, the underlying position to this is that the GP primary care was into trouble before COVID and has been under-resourced for a long time, and people saying that clearly politically is part of the answer to the question, you know, to some of the pressures that you're facing now. And for us as elected members, who on the one hand face the challenge constantly of having residents come to us complaining about their experiences, that has to be part of the message that we're giving back. And I'm interested in what you just said about that national campaign by the BMA, and I think perhaps Susan, myself and others will take away and think about how we can, in a constructive way, kind of complement some of those messages as well. Rob, back to you.
Yeah, so I was just going to say, there's it feels to me that there's a broad consensus here that we've got an opportunity to make things better, but that'll mean making some changes. And you know, I think what I've heard from various folk and some of our GP colleagues in the chat reflects, I think, where we are. So there's a need for us to have a primary and community strategy which reflects that people's mental, physical and social needs need to be addressed in the community, in their own homes. And having list-based general practice at the heart of that's a good thing, but GPs on their own aren't the answer. So I think Martin Rowland's work, Professor Martin Rowland's work around the workforce in primary care played a bit to what we heard from Brian. There's a whole raft of people who work in this space. They don't always work together, and people don't always know how they get signposted into the right place or connected. So it seems to me that what we've got at the moment is a system where if we're registered with a GP, we've now invested in social prescribing link workers. We've invested in the third sector. So if you've got a social need, there's now an opportunity to get that addressed, not by the GP, but through the practice. We've got community mental health transformation, which is doing the same. So we've got people who are working in primary care as mental health practitioners, making the connection between GPs and specialist mental health services, but filling a gap which currently GPs have to fill. So GPs will not have to do that in the future. It needs putting in place, but it's part of the plan. So your mental requirements, your mental support needs, in amongst the other things that you've got going on with your community, either GP and others through general practice. If you look at the medication and the multiple medications that people are on, as we dissolve CCGs and look at medicines management and support, the more we put that into primary care networks and general practices, the more those reviews are done by pharmacists and their teams and not by GPs. So again, you've got a medication need, you've got a mental need, you've got a physical need, social need. There's teams starting to be built around primary care that can address it. And then if you look at good work in places like Wakefield and elsewhere, if you need a specialist opinion from the hospital or a team of the GP and the consultants, you can have that done now in the community. And all of these things start to say that we need a different model of primary care, which allows you to have that relationship with your practice, but the offer is bigger and it brings everybody together. Now, to address this, we've got an innovation hub for mental health through the Academic Health Science innovation hub for primary care through the Academic Health Science Network, which we're all funding, which is just getting going. We've got a workforce work stream in our workforce strategy around primary and community care. We've got the team working on what does a primary community strategy look like for West Yorkshire, because what it seems to me is this conversation is saying that actually we're probably all aligned in a way we're not very often, that we need to do something different. So it might be that we want to spend a bit more time on this, Tim, next time. Yeah. Because it feels like a great conversation to be having, and it's the bit of the community pharmacy and general practice, the two bits of the system people touch the most. To Councillor Venner's other point that she made way back on the cost of living, two ways this is going to hit us. Inflation, which we'll need to fit into our financial planning, which we're affected as major users of utilities as everybody else, and then on the consequences for people. And we know already from the work we've done on winter fuel poverty and winter warmth and so on that people are making a choice between heating and eating. And it seems to me that we need to do a fairly rapid assessment in our places of what additional support we're going to have to be providing. And again, that comes back to that joined up care in communities, having the credit union, general practice, third sector organisations and so on working together is going to have to be part of the solution, unfortunately. But it's a point well made. Jonathan Webb can pick up the issues around the financial consequences for us, and through all of our place-based arrangements we'll have to pick up the service issues.
Thanks, Rob. Okay, are there any other questions or comments on Rob's report? I suppose the other obvious link between those two items on the cost of living thing is also, if we don't get this right, and particularly around heating and fuel poverty, it will be straight back to a pressure on primary care again, of course, as people turn up with more problems. Okay, thanks. If that covers everything on Rob's report, thank you very much for that, Rob. So we move on then to the tackling health inequalities item, and can I invite Fatima, Joe, Sarah and Kenise to introduce this item? I'm not sure who's going to start.
If I may. Good afternoon, everyone. My name's Fatima Khan Shah. I'm one of the Associate Directors working in the partnership and sharing the overall responsibility for the oversight of the review with the fabulous Sarah Smith. So just to remind colleagues, we've got a slightly changed format today in recognition of the agreement that we made in Partnership Board in the previous meeting, which was to continue our aspiration to use our existing networks, governance, to embed the delivery of the review. So with that in mind, what we've decided to do is to split the review into two halves, starting with the first half, which is section 1 on safe access to work and the leadership, making sure that our leadership is reflective of our communities. And they're the areas we're going to focus on today. I'm going to hand over to Joe Farn and Sarah Brewer to talk through the update from the People Directorate, and then Sarah will talk us through the action for the next meeting. Over to you, Joe.
Thanks, Fatima. Hi, everyone. My name's Joe. I'm the Associate Director for System and Leadership Development. Sarah, are you there?
I am. Hi. Yes, Sarah Brewer, the Associate Director for Workforce Strategy and Planning.
I'm just going to share a few slides which summarise the paper that you should have all received. So just give me a couple of seconds to do that. Sarah, I can see you. Have the slides come up?
They have, yes.
Excellent. Let me just put them on full screen. That changed.
Brilliant.
Brilliant. Right. OK, thank you very much. So, yeah, a little whistle stop tour through some of the work that Sarah, myself and lots of other colleagues actually have been doing on the first two recommendations that came out of the independent review. Just as a reminder what they are, they're about improving access to safe work for colleagues and also ensuring that our leadership is reflective of our communities. There's a link of all of this work to another agenda item that Sarah and I will be talking about later, which is the update on the people plan. So just some assurance for colleagues that these work streams are fully embedded into that people plan and also embedded into our governance as a directorate through a task and finish group, which is our workforce and culture group, and also through to the people board as well. So we've got lots of attention on how we get this work done as a directorate. So just to give you a feel for some of the stuff that we've been doing and the progress that we've been making, each of the two recommendations are kind of split into 4 pieces of work and contributing to each of those 4 are lots of different work streams, which I'll just give you a flavour of. And Sarah, please do jump in. So the first priority for recommendation 1 is about how we share information. So there's a lot of kind of stuff that fits under this priority. There's how we share information on health and wellbeing resources. We've done a lot of work on creating bespoke resources for colleagues from ethnic minority backgrounds, and there's a link to our website on what those resources are. We've also been doing some work on understanding some of the barriers that people face and specific needs around mental wellbeing through the work of the Mental Health and Wellbeing Hub. We were successful in getting quite a sum of money for 2 years through the Enhanced Occupational Health Fund work with NHS England and Improvement, and there's some specific projects underway that is about developing the right culture of inclusion, a culture of belonging through compassionate inclusive leadership, and that's about developing line manager and peer-to-peer skills. And then we've just launched a piece of research with the University of Leeds around understanding barriers in access to health and wellbeing offers as well. So that's the first chunk. Sarah, do you want to add anything before I hoof on?
I think the only thing to flag is the great work that's been happening within places as part of the COVID vaccination programme, and the outreach work to support colleagues from ethnic minority backgrounds and communities to take up the vaccine. So I think there's been some real innovation and real local partnership work in there with our communities, which we can learn from.
Thank you. Yeah, of course. The other key bit about recommendation 1 is how we increase employment pipelines and access to employment for people from ethnic minority backgrounds. And again, you can see a reasonably sizable list there of some of the work that we've been doing, including Step Into Health boot camps, which is all about access to non-clinical roles. Our colleagues from Health Education England are working with some of our provider organisations, schools and colleges to understand barriers in terms of taking up apprenticeships. We're also doing some work with the Prince's Trust to support young people from diverse backgrounds into mental health specific careers. Key focus in the West Yorkshire Retention Programme on increasing and celebrating diversity. We're doing some work with breaking barriers into innovations in partnership with lots of our partner organisations on how we develop local strategies to tackle health inequalities. And also, finally, but probably not an exhaustive list, working with West Yorkshire universities and higher education and further education establishments to widen participation as well. So that's the first 2 chunks of the first recommendation. The next 2 cover risk assessment. So again, we've been doing stock take on our process for risk assessment from a health and wellbeing point of view across our provider organisations. And that's about understanding any patterns, insights, learning that we can take from how that has been done in the past. And also that it's embedded into our people plan as well. We've got our looking after our people pillar, which is one of 5 priorities in our people plan, which is all about enabling the workforce to stay safe and building on the support, the kind of significant support, I guess, at the beginning of the pandemic, but how we bed that into how we do things for the long term as well, and we continue learning from that. And then there's better people than me to talk about this next bit, but understanding the impact of racism and having more conversations about that impact. And you'll be well aware, and I know many of you directly involved in the anti-racism campaign, Root Out Racism, and I know Karen Coleman's on the call, so I'm not even going to attempt to describe some of this, but we've got an evaluation report also attached, which shows the level of engagement, which has been really significant, and the impact of that movement as well. So I think that covers recommendation 1. For recommendation 2, this is all about ensuring our partnership leadership is reflective of our communities. So again, there's 4 kind of significant parts to this as well. The first is about equity of access to roles. So this is all about tackling one of those workforce race equality indicators about the disparity between the ratio of colleagues appointed to post following shortlisting. So we've got a direct measure for this that we can keep an eye on as well. And a big part of this has been how we redesign our recruitment practice. So an overhaul of our recruitment processes to make them more inclusive. We've got a toolkit, some resources and some training now available. We launched that during our Connected on Inclusion week, which I know other colleagues will be talking a little bit more about later. And we're also testing it in Bradford and Craven Place, and Sarah and I are also testing it as we recruit people to new posts in the People Directorate as well. So this bit has been designed, it's all about embedding it into our practice now. Another part of this is about how we ensure that colleagues from ethnic minority backgrounds have access to development opportunities that are not necessarily just mandatory training, so further career development opportunities. So we're about to launch an ILM5 coaching programme for around about 20 colleagues from ethnic minority backgrounds. That was a key ask from some of the people that are doing our fellowship programme as well and our race equality network. We've also just launched our reciprocal mentoring programme between system leadership executive colleagues and colleagues from ethnic minority backgrounds as well. So that is go, and there's 17 pairs as part of that. We've also got our racial inequalities training that we designed off the back of the Black Lives Matter movement over a year ago, and in that year we've had around about 200 people having taken up that offer of training, and as part of the training they make a pledge as well of what they're going to change in terms of their individual practice as a result of the training. We're also doing some work on cultural competency and sensitivity training. We've got a whole heap of stuff actually available out there, but what we're doing is mapping that to understand what's available and looking at where there might be some gaps and creating a West Yorkshire-wide offer to connect people. And then we've also had the Connected on Inclusion Week, which I won't say too much about because we've got that later on the agenda, haven't we? And then the final couple of bits was about setting up independent discrimination panels. That was all about trying to understand, again, the disparity with colleagues from ethnic minority backgrounds being taken through things like disciplinary processes, grievance, that kind of thing. So we have made some progress with that. We've been mapping kind of existing trust policy procedure, looking at the kind of improvement to informal process before things get into more formal process, and also the setting up of some panels in some organisations as well, and looking at how we do training with our HR team colleagues, line managers, etc. So that has started up. More to do on that, I think, fair to say. I think our colleagues that we would engage with on that from HR teams in our organisations, you know, up until fairly recently, were really under pressure with the VCOD, the Vaccination as a Condition of Employment work. So we will be looking to kind of put some more energy behind this piece of work in the coming months. And then the final bit is the representative leadership part of this, and we've got our fellowship programme well underway. We launched that in November 2020. We've now got 2 cohorts running of around about 20 people, and that's all about building our own talent pool in West Yorkshire so that we can increase the amount of people from ethnic minority backgrounds at senior levels and at every level eventually as the pipeline grows, and then linked to that, looking at what we do to support our Race Equality Network colleagues in their own talent and development and skills. So I'm going to pause there. Sarah, do you want to add anything before I hand over to Kenese?
No, that's been great, Jo, thank you.
Okay. Or in fact, Kenese, just before I do hand over, just in summary, as I've kind of alluded to, we've got loads underway actually, tons and tons there. Our next bit is about how we embed those things into our way of working, our business as usual as West Yorkshire, just how we do things around here, our culture. We need to keep communicating and engaging on all of these initiatives so that people know that they're available and how they can access them. So that's a continual thing. Again, I've kind of touched on this, but key in our next phase is how we demonstrate the outcomes of these initiatives, and how we measure the improvement that we're trying to make as a result of them. And then resource is going to be key for keeping the energy going on this, not just resource from like mine and Sarah's team, but the kind of capacity to engage in all of our partner organisations as well. So Kenese, I will hand over to you at this point and I'll move the slide on. There we go.
Hi everybody, I'm not well today, so bear with my voice. We're really pleased to see the progress of the workforce on the workforce, but recognise there's much more to do. What we see is that it directly impacts on community, the relationships and how people are within their working roles and how that can impact on life outcomes for health outcomes for the people that are accessing the services. So we want to know how do we start to measure impact utilising the metrics of workforce race equality standard metrics with some focus on sectors and places. So what we want is like the res data. We want a similar data from the LAs, we want similar data from VCS groups all in one place so we can compare and contrast. And then once we've compared and contrast, we can see where there's areas of excellent practice that can be learned, that we can learn from, and we can progress as a whole partnership rather than individual trusts in silo, individual LAs in silo. Is there an opportunity to pull all this together in one place? That's what we're asking. Is there an opportunity to pull that data into one place and support the thread of work that I've just described? We're also thinking about our June meeting, and we're already starting to work on that. And we need to, in the June meeting, we need to recognise the VCSE sector has a key role in supporting this whole agenda and the wider review recommendations. We want to know about commissioning. We want to know how the money goes and where it goes to, which areas it goes to, which areas need it the most, so we can narrow the gap of health inequalities. We do recognise again that a lot of work was done on COVID-19 and vaccine engagement, but the area where I live, we had the lowest hair health in Leeds, we had the lowest uptake of the vaccine in the whole of the country. How can we still have, that's still probably the same data now. How can we have utilized the VCSE sector, the tiny groups, to help to have access to the vaccines? So we want quality on the ground and see how we can utilize the small groups as well as the larger groups that are the obvious ones that are easy to go to because they are the obvious ones. And more than anything else, we want to know how this is going to be resourced accordingly. And I think that's it from me today. Thank you.
Okay, thank you. So questions or comments, please, on that presentation and the report? Clearly covered everything to your satisfaction. Oh, sorry, bear with me. Yes, Simon.
Thank you, Councillor Swift, and obviously all the work that's happening that Joe, Sarah and Kenise have just fed back. A question from the Race Equality Network was around, it just picks up on that point, Kenise, that you just made around how we measure the work that's happening, and as well as quantitative but qualitative data that we can use as well. So an ask around what the business intelligence sort of support we get for being able to really clearly articulate the difference and the impact we're making. I think it's quite obvious there's a lot of work happening, but to be able to really articulate what difference that's making. When we talked about Sheila from Chaptertown that said, how's this work going to make a difference? And I think for people to be able to really buy into this is really making that difference, we need to be able to articulate that story so that people at every level can relay that. So just an ask around what that business intelligence or support we can have.
Thank you. Somebody want to come back on that one?
I can start with that one.
Yeah, thanks, Rob.
So I think there's actually, I'll just start in a slightly different place first, Simon, and pick up one of the questions from Kenise, really, which we could all commit to in principle now, I think, which is this thing about having consistent data from all sectors. So the NHS has the Workforce Race Equality Standard with 10 standards in it, and you know, they're about number of people going into disciplinary processes, success on shortlisting and recruitment, and so on. So we don't currently have a consistent set of data for third sector, local government and the NHS. So do we feel that we could and should have that? So we could agree to that in principle, I think, as a group. And then secondly, we need to make sure that the business intelligence work that we've got going across the partnership picks this up as one of the key 10 ambitions. You know, it's linked to the 10 ambitions. It's the standing item on the partnership. And Ian and the team are looking at the business intelligence support in the operating model. So I guess it is a priority. I would say business intelligence capacity in West Yorkshire needs to be strengthened. As we used to have a sort of CCGs used to have support from something called Embed, that doesn't exist anymore. We've got good developments like the data hub in Leeds, which Tim Riley could talk about, but we need something collectively we can use. So I think it's a good shout, Simon. But perhaps, Tim, we could ask people if they're committed to getting that consistent data across all sectors.
Thanks, Rob. Yeah, we'll pick that one up. Kathy?
Thank you. Good afternoon, everyone. For those of you who don't know me, I'm Kathy Elliott. I'm Chair Designate for our new West Yorkshire Integrated Care Board. So thank you for the presentation. Thank you for the document. It's really good to start seeing the progress being made or the aims that can then be reported on in the future, which is really welcomed. I suppose actually I want to ask a different question, but just that point made on data, I think would be really helpful for leaders and organisations to understand what needs to be collated to be reviewed within our partnership and what would go in the public domain. And I appreciate sometimes people might be feeling a bit sensitive about information, but it's important to have it out in the open amongst our partnership, at least, to be able to support each other. And it's great to hear about the training. My question particularly was around what we can do as leaders to remove any barriers you're facing at the moment, or what can we do that are quick wins or longer term aims? So you talked about training packages. Is everyone taking that up, for example? So if there's anything you can let us know now or in future meetings, I think that'd be really welcome. You've got an incredibly influential group of people here that hopefully can help you progress the agenda.
Thanks, Kathy. Fatima, do you want to come back?
Yeah, I mean, Councillor, I'm not going to miss an opportunity if people are asking me what we can do and what I can have. I mean, I'd be a fool to say no, wouldn't I? I think in answer to the first question about the data and is there an issue with the data, yes and no. So a lot of the data is already available in the public domain. Our organisations public them on an annual basis. The issue we've got is as sectors, we measure different things. So if we're trying to look at this as a partnership, there's a bit of work that needs to be done to amalgamate the data in a way where we're looking at consistent themes. And that's kind of where the hold up is, which is why I'm really pleased that Rob's flagged the BI intelligence situation and that Ian is resolving that. I suppose your other question about is there anything more we can do? Short answer is yes. So one of the overwhelming bits of feedback, and I'm really pleased that Rob reiterated this in his chief executive update, is that our network members and our colleagues that are leading on this agenda, quite often from ethnic minorities, are doing this on top of their day job. And they've had a really difficult 2 years. They've dealt with a pandemic. Disproportionately, they've been impacted by that pandemic and have lost people. And they're dealing with the emotional load of the Black Lives Matter movement and triggering news-related items every single day. You only need to look at social media to see that there was instances in the media in the last few days that have really triggered people and made them feel really bad. So I think there's a sort of wealth of feeling that is developing amongst the organisations and our network, which is we really believe in this. We're really proud of what we've done. We've put our heart and soul into it, but we've given it all and we're tired and we can't sustain this. And the ask is for some resource, for some capacity and an infrastructure to keep this momentum, which is why Rob's call to action is so important, because although we've committed to protecting the Race Equality Network members' time, that's not actually feeding through to the line managers of these individuals. So quite often they're doing the extra work in their own time, and that's where the risk is coming from. And also, you know, the work of our allies as well. It isn't just the network members that are leading on this. So you ask, and my response would be, if we could do that, that would be incredible. But also an infrastructure to keep the momentum on this, because we are the best ICS in the country on this agenda, and I'm committed to keeping us that way.
Thank you. There's a couple of people in the chat endorsing Rob's point about the consistency of data collection as well. So I hope we can support that. I mean, in terms of that, I don't know how we make sure that's communicated back to people. Obviously, it's been raised here and would be in the minutes, but perhaps perhaps we should think about some sort of other appropriate communication back to relevant leaders in each organisation to make sure it's emphasised as well. I think that's a strong point you made there, Fatima. So perhaps we can find a way of taking that back from this. We're happy to endorse those. Are people okay if we move on to the Connected on Inclusion one, which obviously has some connections? I think that's Saima, Hayden and Fatima again. Saima, are you leading off on this one?
Sorry, Councillor Smith, I think before we started the agenda item, Sarah had her hand up.
Oh, sorry, yes, I just missed that. Sorry, Sarah. Yeah.
Sorry. Hi everyone, I'm Sarah Smith. I've worked with Fatima leading the overall race equality review and I'm consultant in public health at the partnership, for those who haven't met. Just really quickly, as Fatima alluded to at the beginning, wanted to lead into what we'll be focusing on in June on the race equality review. So we will be looking at a focus on commissioning, some population planning and mental health outcomes. I thought it was important to mention because it was something that came up again really strongly in the VCSE Voices panel around understanding how we are allocating resource to address inequalities through the voluntary and community sector. So I wanted to raise that that's something that we'll bring back in June, along with some feedback from some of the health inclusion groups that are really at the sharp end of institutional racism. So we're working with gypsy and traveller populations and refugees and asylum seekers, and we'll bring back some progress there as well as on the mental health outcomes. So that's just the next steps with what we're going to bring back in June in regards to the race equality review. Thank you.
Okay, thank you, Sarah. And Kenese, you want to come back?
I just wanted to say that I've had feedback from our VCSE sector on the fuel poverty. Some of our centres are going to have to close because they can't afford their gas and electric bills. And that's something we really, really need to think about, because they save lives every single day. every single day. We can't afford for these types of centres to be closing because that infrastructure is going to be gone. And I don't know how we're going to support that, but Sarah and I have started conversations on it, but it's something we need to keep an eye on as well. Thank you.
Okay, thanks for alerting us to that one, Denise. Again, we'll make sure that's followed up. Okay, Simon.
Thank you, Councillor Swift. I am actually going to hand over to Fatima because she's going to kick this.
Yeah, you're all going to be sick of me as a board in the next 20 minutes, but I promise you I will be very, very brief. So it is with great pride that we bring this paper to the partnership board. I don't, make any apology for saying that as a British Asian Muslim woman, I am proud to live and work in this system, because there is so much that we do that we should be really proud of. But the rationale behind the Connected on Inclusion Week work came from a number of conversations. One, of course, is always with Rob about what we can do to make this work real, but also based on a number of sort of bits of feedback that I've had from colleagues from across the system who reflect on, although we're doing some fantastic work on this agenda, it doesn't always feel real because it's quite systemic, it's very central, it's very strategic. And actually, what does it mean for a Band 5 nurse working in our acute trusts, or a social worker that's going out to people in our communities, or for Sheila in Chapeltown? And what we wanted to do was to pull together some information that showcased that, yes, we are making that impact in our grassroots, making it real for people in our communities, but also giving the people that are making this magic happen in the grassroots of our communities and organisations the opportunity to have that spotlight and to showcase what we do. So if I could have the next slide, please. One of the amazing things that I think we did with this conversation was, and it's not going to surprise you all for me to say this, was we didn't keep it regional, because why would we? There's an opportunity for us to really influence the agenda nationally and share good practice, but equally pinch with pride, because there's so much more we could do. But equally, we did go international, because again, why wouldn't we? And there's some really good opportunities and workshops that if you haven't seen already, please do go back and watch, that have showcased some of the fantastic initiatives that have taken place across the region. So what we've tried to do is hear the feedback from people across our communities on making it real, developing those connections, spreading the good practice, learning from each other, because even in our own system, sometimes we don't talk to each other because we're too busy doing. Showcasing the opportunity to spread the initiatives that we know are working well, to embed them within our systems, because as you know, our mantra in West Yorkshire is taking the work and the magic, the things that make things better, to the people in our communities, but always looking to the horizon, because there is so much more to do. So how do we build better forward? But also, are there people we can link in with, say regionally in the north or nationally, to really create the space and build on some of the issues that we know are not just a West Yorkshire issue, they're affecting the whole country. So like you can see on the screen, we had a whole range of events. We've got the incredible Michael West, Habib Naqvi, our local mayor, Councillor Pandor, elected leaders, people from HEE, NHS England, all coming together to have this really, really important conversation. And it felt like a really collaborative event. It had the opportunity for people to really shape the conversations, take things away, but also have really honest reflections about how tough this is. So when we present this, I mean, inevitably, because I'm talking about it, I will always put the positive spin, because it is positive, our approach, but it's also really difficult. And some of the honest reflections from very senior influential people was, I'm really struggling with this, but the opportunity to come and talk to you all has enabled me to feel like I can, and there are things that I can go and do, and also connecting with you will enable me to make that happen in our own places. So there's a resounding message that we are, affecting the whole country for the better, not just West Yorkshire. So I'm going to hand over to Hayden now, who's going to talk you through some of the practical elements of the week so far. Hayden, over to you.
Thanks, Fatima, and just to say hello everyone, I'm Hayden. I've been with the partnership actually for a year today now, which is quite strange for me to say out loud, but no, really lucky to be here and really privileged to be involved in this work and fundamentally to be an ally on this. So I think what Fatima's just really nicely outlined is that sort of journey we've been on and why we reached this point of planning and ultimately hosting the Connected on Inclusion Week. And so if that's kind of why we did it and that was the rationale, then I suppose the glaringly obvious question is, how well did we do in some ways, and what are we going to do with that? And I think these 5 quotes here, and whilst they are just 5, begin to show that real sort of profound impact at a personal level really nicely. Kind of statements of it raised awareness, it was rejuvenating, it was heart-wrenching, and I don't think any of us want anyone to feel that way, but I think what that does play to is what we speak about quite a lot, that we have very real conversations about very real issues, and we do what we can to tackle those through conversation and through action. And also that it was a privilege, and I've said that that is similar to how I felt, although that's not my quote. And as I've said, they are just 5, so to speak. But if we take the spirit of what's in those 5 quotes and really transpose it onto the scale that you can see in this nice little flight map that shows that sort of connection across a range of organisations, almost 1,300 people, the 7 NHS England regions of England, 3 of the 4 nations that make up the United Kingdom as well, you can really start to understand that sort of breadth and scale of impact. And I think in addition to this, what we were really keen on throughout the week is that we connected with those near 1,300 people that registered, the people that were at the events, but that we also pushed it through our social media. And anyone that knows anyone in the partnership will know we're really big on social media. And so we had our own Twitter hashtag, and we're really pushing that. And it was pushing out around 200,000 tweets during the week-long period. We were reaching 40,100 impressions per day. So if you kind of look at that over 5 days, we've got just over 200,000 impressions. And if you think, okay, all 200,000 people that see it might not act upon it, but let's say 10% do, you've still got 20,000 people if you consider that ripple effect. 10% might be ambitious. You can scale that down to 1%. You've still got 2,000 people that may have seen the spirit and the message of Connected on Inclusion and really taken that forward. They've had a conversation, and again, you consider that ripple effect. You can start to really clearly imagine and envision the impact we've made. So I think what this does really is it sort of sets the scene nicely for how Connected on Inclusion, as part of our much wider inclusion efforts as a partnership, really adds to that foundation and sort of would enable us to deliver on what my colleague Simon is going to go over now. So Simon, over to you.
Thank you, Eden. And so for those that haven't met me, my name's Simon. I'm the Assistant Director for System Leadership and Development. And nice segue into why then we take forward the impact of the week and the scale and reach that we had through the week and what we wanted to do next. So we were lucky that we got some funding from NHS England. They commissioned a report and we got £50,000 from them, which was really fantastic to be able to really turn this week into something tangible that we can then take forward. So what we did was we've done a report, which is a part of the papers of this partnership board, and really summarises what we want to do now with all the actions that we then co-produce, the ideas that people came up with throughout the week that we want to take forward. And one of the things that I'll really highlight here is, and Rob talked about it right at the beginning, is we know that there's already lots of national work going on and regional work that we're doing across West Yorkshire. So what we didn't want to do was just have a separate report. We will be aligning this with the work that's already taking place across our region and nationally as well. So the rationale behind that is that we've produced these 2 high quality products that we can share. We've got an animation video that we'll play in a second as well after I finish these slides. And the idea is that we want to keep this momentum going. We're connected on inclusion, but we know that we've got a lot more to do. So we wanted to really use some of that funding to be able to continue that conversation, really influence and catalyse change beyond West Yorkshire, and have a clear action plan for us to just hold ourselves to account. And I think we've heard some of that through the previous paper about our independent inquiry as well, to make sure that we do make an impact with the work that we're doing. Next slide, I'll just touch on the actual outputs of the action plan. So I won't go through this in detail, obviously it's part of your pack as well, but just drawing on a few of the plans that we've got that came out from people that attended across from our own partnership and across the country as well, building on the work that we're doing already. So things around establishing forums for sharing learning, for increasing that diversity at board level, and just to touch on some of these actions we've already started to deliver as well. So we're working with some national colleagues to put that in place. Undertaking further work on strength and ethnicity data, so that really chimes with the work that BOL has been leading nationally around the core 20+5 work around health inequalities, the action point number 9 there about exploring issues around access to services, again that links in with the Race and Health Observatory report that recently was published. So you'll be able to see from this, some of this work aligns with actions that we're already taking, but hopefully takes us to that next level where we're talking about connecting on inclusion, really amplifying that voice of our people so that we can start to really make a difference together and build on what we're already doing. So I'll stop there because I'm mindful of time. We've got an animation video, but I'll just hand back to Fatima to talk you through the recommendations.
Should we play my apologies, Simon. I was just going to say it might be worth playing the animation first, which might help colleagues with the recommendations then. Would that be okay?
Yeah.
I'm crossing everything that this is going to work. This is where it's either going to go all really well or really badly. But either way, we're going to remember it, aren't we?
Reflect, connect and improve.
What have we achieved together?
We're working to make positive change that will last forever.
Across the West Yorkshire Health and Care Partnership, we have 10 big ambitions which include
a diverse leadership that better reflects the broad range of talent in our community.
Reflecting on our journey, we have come a long way already.
Diverse representation in senior decision making,
as well as creating a talent pipeline to make the most of our skills.
An anti-racism movement, a focus on inclusive recruitment.
We know we are shifting cultures for the better.
Connecting with others and celebrating the progress we've made.
A week-long event, 1,300 people across 45 cities, mobilising a movement that won't be swayed.
Compassionate leadership.
Ready to rise.
Resources launched.
Local places and connecting integrated care systems
are just some of the events that were held.
A shared commitment, a purpose to connect on inclusion, an unwavering drive.
Celebrating our people's achievements.
Feeling appreciated, rejuvenated, inspired to do more.
All connected with a collective sense of pride.
Progress made, with much more to do.
We're continuing this journey of improvement and inclusion too.
Allyship, shared learning, mentoring, diverse voices and national conversations.
Lots of ideas to improve.
We will keep the momentum moving.
Keep connecting on inclusion.
Always aiming to do better.
So reflect, connect and improve.
What more can we achieve together?
Let us know. Get in touch, share your ideas.
Let's come together.
West Yorkshire's Health and Care Partnership is connecting on inclusion.
Thank you for that, Hayden, and I can't tell you what a huge sigh of relief that was. That went okay. So just in summary, I think you can all appreciate that this is a demonstration of the fact that this work is making change happen in our communities and the grassroots of our organisations. It's what makes our partnership the amazing entity that it is, and also sort of showcases and consolidates our aspiration to do more. So the recommendations for the board are, first of all, to receive and approve the publication, both the report and video, because I can assure you I've got big plans for it to get it everywhere. The second is to receive the update on progress, because one of the key things that we're committed to do is to keep this momentum, recognising the intersectionality between not only race, but gender, living with a disability, LGBTQ+, etc. We want to start to build the momentum behind all these agendas. And one of the things that our network really recognises is the fact that we're not just one entity. There are many facets that define us and make us who we are. And the final one is just to continue to support the cross-system delivery. Obviously, we've got a number of actions, and one of the things that I think would be really important, and again, Rob, who's always ahead of the trend, alluded to this, is pulling together all the different elements that have come out recently. So we've got the Race Health Observatory report, the BMJ, the medical res, this report, and it would be great to sort of consolidate that into one approach that our places and our organisations can really get their head around and adopt and make their own, because we're all about place, aren't we? So on that note, I'll hand over back to you, Councillor Swift, to take any questions, but also for support on those recommendations.
Thank you. Thank you. So Yeah, so any questions or comments, or people can be happy to endorse those recommendations, and particularly the sharing. Rob, yeah.
Just very happy to support the recommendations, and just to commend Karen and the team for their approach, which always includes, I think we've got an easy read version, we've got plain text format, and we've got an audio version of the reports, which are ready to go at exactly the same time as the standard report, which is exactly how it should be, really. So I'm really grateful for the team for always making sure that we have as many ways of accessing material as possible.
Okay, thank you, Rob. I'm not seeing anybody else, so can I take it therefore that we are happy to endorse those recommendations, and a big well done to everybody involved in producing that. Yeah, Fatima, yeah.
Just very briefly, Chair, I forgot to at the beginning just say a huge thank you to everyone who contributed and made it happen. There was a huge group of people behind the success of this, and it would be great if the board could acknowledge their contributions as well. Rob just prompted me to make sure I said that. Thank you.
Yeah, absolutely. Can we add that to the minutes and the recommendations? Okay, thank you. Right, moving on. Just patient of public voice. We're going to be sharing a video which is part of the Life Loss and Learning Legacy project, and I'm not quite sure who's launching this one for us. Lauren, thank you.
Me and Julie met in 1973. I was about 17 or 18, so she'll have been about 16. And shortly after that, we started dating. And funnily enough, I just knew right from the start that she was right for me, and the rest, they say, is history. We went out with each other for about 5 years, and it was 1978 when we got married. We were married for 42 years in total, had 3 children, had a wonderful life together. She was so good at caring for people. She was so selfless. Towards the end of last year, I did notice she was becoming more forgetful. Late in February, I got a message from Julie's close friend asking me whether there was something wrong with Julie, because she seemed like she had a brain fog. That's when I got Julie an appointment almost straight away. This was just prior to lockdown, and the doctor started asking her questions about her health. She asked her if she was depressed, and she said no. And she said then that she was going to do this cognitive test. I think that Julie wasn't in the right frame of mind to do that test. And it might have been just a bad day. Diabetes might have been raging, her sugar levels may have been high. So when it came to answering the question, she maybe wasn't in the frame of mind to concentrate on answering it properly. And it was a few days after that she received the letter inviting her for further tests from the Younger Persons with Dementia team. My wife was 62, and the doctor was talking about early onset dementia, and that, if you do get it at that age, is quite devastating. I tried to play it down a bit and say, look, they're only just trying to look at the possibilities. But what she wrote in a personal diary was that she read a shocking letter from the hospital. They think I've got dementia. And that was how her mind was thinking at the time. And that appointment was set for the 7th of May. And that coincidentally was the day after Julie took her own life. After she died, obviously COVID had a massive impact on me and on the family, on our ability to mourn. The funeral was limited to 10 people. And even then, her mum, who was 95, she was advised to socially distance. So she sat in like a different part of the crematorium to everybody else. And although it was a nice service and there were some nice words spoken, it wasn't the same without the support of more family and friends. I was reasonably confident that I could deal with the inquest. I had no illusion about the inquest itself, that it was just a formality that everybody had to go through by law. I was told they wanted an account from me of what had happened with Julie. I sat down and I just started writing some background notes, and then circumstances leading up to Julie's death. some relevant issues and some lessons learned. When we went into the inquest, the coroner explained that the purpose of the inquest is to ascertain how a person died and not why they died, and that that's all the law requires. He has to deal with facts. So when I say this may have led to Julie's suicidal thought, he will say, yeah, but that's conjecture. And this is a legal thing. Unless you've got a legal mind, you just know what is right and what is wrong. And something that seems relevant to us might in the court of law not be relevant because it's conjecture. People ask me what was the outcome, and the outcome was that Julie took her own life, and we knew that right from the start. So that wasn't a revelation. So really, it's just a way of closing the book, and that's how they deal with it. There's been a lot of talk about the impact of COVID on people's mental health, and it didn't need a letter from the Young Persons with Dementia team to carry out further tests. They could have done further tests without even mentioning the word dementia. That just opened up a whole can of worms, and something Julie was having to live with during the COVID period when there was not a lot going on in her life. Had she sort of gone into that COVID period and been going about a normal routine, she would have probably been too busy to dwell on it and even worry about it. She would have just been doing what she normally did, which was looking after other people.
So thank you for sharing that. It's obviously an incredibly powerful testimony, and meant really to provide an introduction to the next item, which is around the suicide prevention strategy and action plan. So unless anybody wants to offer any immediate reflections on that, perhaps could ask Kim and Jess to introduce this item.
Thank you, Councillor Swift. So it's nice to meet you all. I'm Jess Parker. I'm the Suicide Prevention Project Manager at the ICS. I'm actually going to turn my camera off just because sometimes I have connectivity problems. So Kim, do you want to come in next? And Keir and Sarah are here as well and support this item.
Hi, I'm Kim Shuttler. I am one of the new joint SROs for suicide prevention for the ICS, and my day job is I'm the Chief Executive of the Cellar Trust, for a mental health charity in Bradford. And in Bradford and Craven, I also chair the Voluntary and Community Sector Assembly.
Sarah, do you want to just say hi, and Keir as well, if you're here?
Thanks, Jess. Hi, I've introduced myself before. I put a cardigan on now, so it's not another layer of disguise. I'm still Sarah Smith, still in consultant in public health. Really happy to say that the suicide prevention agenda, we've been linked in with public health for a while now, and when Jess started, we had a conversation around actually sitting the suicide prevention programme within the Improving Population Health programme will give us a much further reach in terms of determinants of health and upstream prevention. So from beginning of April, the suicide prevention programme's moving over to the Improving Population Health team. So hence Keir and I doing sort of a bit of a double act on this today. We'll still work really closely, sort of matrix working on it, but that's where the home for the work is going to be from the beginning of April.
Thanks, Sarah. Just to complete the loop, so hi everyone, my name's Keir, so I'm the Programme Director for Mental Health, Learning Disability and Autism, so on behalf of the Mental Health LD and Autism Collaborative and the wider ICS.
Thank you.
Great, so I've got a presentation to share if that's okay. We are here with our new suicide prevention strategy for West Yorkshire, and it would be amazing if I could just take you through a few slides. You've got a copy of the full strategy. And obviously, hopefully there'll be some time for some questions at the end. So let me get onto the right format. Yep, so that's who we are. So why are we here? Well, we're here because suicide is actually our biggest killer of men under 50 in West Yorkshire and our biggest killer of young people. So it is a really, really, really important agenda, as that film has shown. We've got a new strategy for the next 5 years, and what we're saying in that strategy is that we believe that suicide is preventable. So we believe that these deaths can be prevented, and we have a vision for zero suicide. And in order to achieve that, we're going to continue to embed our priority of reducing the suicide rate by 10% over the next 5 years. I just wanted to take you quickly through some evidence. I know many of you on this call will know all about this, but I just wanted to sort of offer some reassurance that evidence does underpin the strategy. Suicide prevention, suicide data is complex and sort of flawed, but there are some certain things that we can say. So we know that more men take their own lives than women, and we know that suicide rates tend to rise during times of economic recession. And we know there's a particular risk in the middle age for both genders, but averages do appear to be getting younger. And we know from ONS data that West Yorkshire has a significantly higher suicide rate than England as a whole for men and women combined. So my colleague in Improving Population Health, Richard, helped me to prepare this slide, and I haven't got a title because I wanted to make it as big as possible just to show you the kind of what's going on with rates. So this is 3-year rolling rates of suicide for England as a whole, with this thick black line here, for West Yorkshire with the thicker orange line, and then for each of our places. So what we can say is that suicide rates, and this is to the middle of 2020, so suicide rates decreased until about 2017, and since then have been rising. We know we've seen some levelling off in 2020 and 2021, but this hasn't quite translated into the ONS data yet. And I suppose what's important to know about this slide is that with the sort of exception of Bradford, our rates, our ONS data is still showing the rates are on the up. However, there are loads of caveats that some of this data is flawed. Kind of most insight that we get is into what's going on with suicide is that local audits that our place-based public health leads do periodically. So again, loads of caveats around this information. It's slightly out of date, but what they do is they go to the coroner's office and they look at the inquest files for every single person who took their own life or for whom the recommendation was a suicide finding. And so I've just cherry picked some of the information out of our most recent audits here that I think is interesting just to say to you. So for example, in Leeds, 15% of people who took their own life during the period of the last audit had contact with their GP within 1 week of their death, 43% within 1 month. 78% had a documented history of mental health diagnosis. In Bradford, we've got similar kind of figures, nearly 50% having previously attempted suicide and just over 50%, for example, having a physical health diagnosis. In Calderdale, we've got data around nearly a quarter of suicides being preceded by criminal justice contact, with most contacts involving the perpetrators of There's a similar level of contact with primary care, 71% having a mental health diagnosis, and over 50% having contact with mental health services in the last month of their life. A sort of recent review of the cluster of 4 suicides for children in Wakefield found that there were opportunities to intervene in terms of services. And again, another recent research study from the University of Manchester looked at that middle-aged men cohort for everybody who took their own life nationally between the ages of 40 and 54 who was a man, and that showed that 91% of people had service contact and 52% had a long-term condition and 44% has previously self-harmed. So this is some of the evidence that I'm picking out about what we know about the kinds of people who take their own life in West Yorkshire and beyond. So how are we going to address this, and what's our strategy, and what are our actions going to be? So I just really want to emphasise that there are 5 place-based suicide prevention leads who sit in public health and 5 place-based multi-agency partnerships. They've all got their local strategies and they've all got their local action plans, and it was really important that we didn't reproduce any of that at a West Yorkshire level. And so we mapped what would make sense to do once across West Yorkshire. We mapped what would make sense to do coordination, and we mapped what places we're doing at a community level. And so the stuff that's kind of do once or coordinate once is in the strategy and for West Yorkshire, and the stuff that isn't is not. That's in your place-based strategies, and it's really important to emphasise that this isn't the complete solution. This isn't the complete strategy. This is part of our strategy. I hope that makes sense. So what are we saying? We're looking at basically that the balance between the structural inequalities and the kind of difficulties that people face over their life course, the wider determinants of health and health inequalities, with the touch points with the system that we know that our data tells us that people have. And we want to make sure we strike the right balance and do stuff that's within our gift to do. So we've got here a staged, stepped approach to kick-starting different work. Much of this has begun already, and I could give a really detailed presentation on what we've achieved over the last 12 months, but I think it's really important to look forward with this board and to really ask for your help in embedding some of this work. So we've got a focus on some of those touch points that the audits and the ONS data and also our real-time data tells us is important. So and we really want to target resources where we know that suicide is the highest risk. And all of this is explained in detail in the strategy, but we're looking at things like crisis, attempt suicide, unemployment, children and young people, criminal justice, and those who live alone. Physical health and long-term conditions are also key. To the right-hand side here, we've got the kind of 5 core principles which we've agreed at Suicide Prevention Oversight Group will be embedded in everything that we do. And so I suppose a question for the system is, we know that every death by suicide is one too many. How can we and where can we have the opportunities to intervene and to make sure that it's embedded in all of our organisations and in all of our practices, and how can we make every contact count? We need a system, I think, of people who feel confident to have the conversation around suicide, confident to recognise the risks, and confident to know that it's within their domain. And I suppose we've done lots. As I said, we've got a suicide prevention portal, for example, for West Yorkshire, which has received really, really good feedback. But I guess the question is, how do we map out the strategy and the action plan to achieve the biggest possible impact? I'll stop sharing now. I'm not sure if Kia, you want to come in there.
Yeah, thanks, Jess. Really, really helpful. And just to kind of add a bit of kind of wider context, I guess. So Jess talked a lot about kind of the breadth of responsibility there for different partners across the system. And obviously there's elements with regard to the suicide prevention agenda that are specific to the mental health trusts and how we kind of our trusts interact with one another and learn from one another. There are bits about kind of how service provision, where that's kind of relationships between NHS providers and Yorkshire Ambulance Service and West Yorkshire Police work. Then there's the broader piece around kind of the everyone's responsibility piece and the really, really critical importance of kind of relationships in our communities with the voluntary and community sector. So it's a really kind of broad piece. But what Jess did touch on is about the impact as well of those people who have been in touch with some service in some form and maybe not got the support that they needed. And I think one of the reflections we need to have is from a wider mental health, learning disability and autism programme point of view is we are still seeking to transform what we do in those services. We're still seeking to invest and commit to continuing to invest in those services as much as we possibly can. And I think that's a commitment we need to keep held in our minds as we go forward as a partnership, about how we keep that commitment high to investing in that service provision, how we make sure that we're supporting staff to kind of develop their skills and to kind of be resourced well enough to be able to support earlier intervention, because suicide is kind of the tip of the iceberg point essentially. So yeah, really, really helpful, Jess, thank you. And just to say that the key thing about trying to bring all partners together and what each aspect of our system can do is kind of the key statement for me, I think, in today. But I'll stop there. Thanks, Jeff.
Kim, I don't know if you'd like to come in as well as one of our 3 excellent SROs for this programme.
You've covered all the key statements, but I was really heartened, I suppose, to have the opportunity to be one of the joint SROs, because I think that was a clear mark in the sand for this programme to have different SROs who come at it from a different perspective. So with the voluntary community sector hat on. And I think Jess, with her background in the VCS, has been, you know, instrumental in terms of helping to broaden this agenda to consider that much more in terms of the wider determinants of health, but also the vital role of communities. So we've seen the power and the ability of communities when we take an asset-based approach. I guess what I would say is, from where I sit in the sector and from what I hear, and it probably overlaps with some of the stuff that Kenise was saying, is it's a really, really difficult, desperate time for so many people in our communities, and it's going to get worse. So as we are in this cost of living crisis, and as we wonder to ourselves whether or not people are going to be able to afford to feed their families, or whether they'll be able to afford to get the bus to come and access our services, as we head into that period, what does that mean in terms of how do we mitigate against that? Because it's really challenging, isn't it, to measure things that, you know, measure what you're preventing. But I suppose the rallying call, we were talking, Kieran, Jess and I were talking about what is the ask to you, and the ask to you is is we're here with a rallying call to say, what is your role in this? What can we do differently? Because we're heading into a time where our staff are so under pressure. You know, everybody's like, here's a strategy here and there, can you do this and that? But we think about the people who, you know, who are having that contact, those contacts with people. If we think about each of us have a little bit of power, or maybe a budget or an agenda, where can we all play a role? So maybe there's something about individual pledges. Maybe it's something about going back and have a really to coin the phrase of my good colleague Helen Hurst, have a right big think about this. Because I think we do need a right big think about this in terms of what we can all do to mitigate on what's going on now and what's coming down the line, and also resource it properly. I think our resourcing is patchy across the ICS, so, you know, how do we make sure we're investing in this in the next few years, and how do we hold ourselves accountable would be, I guess, the question for us all to think about.
Thank you. Rob, you want to come in?
Yeah, I see this good question from Ian about measurement. So two things really. I think what we can all take away from the presentation and the analysis are that there's quite a lot of myths around suicide which we need to bust. And the two big ones, I think, are that people who die by suicide have all got, you know, are all in the mental health system. Actually, you know, the majority of people who die by suicide aren't in touch with specialist mental health services, but they are in touch with somebody, which is what the analysis shows really clearly, which is why it's everyone's business. And the pandemic has caused an increase in suicide. It hasn't. So what we see, but what does cause an increase in suicides, lots of evidence for this globally, is recession. So we're now at a point of significant risk, going back to the cost of living issue. And what we need, I think, is this is why it's important that this is everybody's business. So there's been huge strides taken in mental health services over the years to reduce the number of people who die by suicide on admission to a mental health unit and on release from a mental health unit or discharge, because that's why we have intensive support on admission and intensive follow-up when people are discharged from care. There's still a huge amount more that mental health providers can do in this space, but what we need, I think collectively, I think if we've got this narrative, is it's the biggest killer of young men, it's the biggest killer of young people. It's something that affects people mostly who aren't in touch with specialist mental health services. So, and that means that it's everyone's business. I think the more that everybody can do the Zero Suicide Alliance training to raise awareness around how you deal with the issues if you come across them will be really helpful. And then I think it's the targeted interventions and the resourcing that we need to address here. And I think the strategy is good because what it does, it sort of takes that high level picture and tries to put in place the actions that are going to make a difference right across all elements of the system. And I think that the measures that are described and the actions and the outcomes are exactly the right ones and are exactly the way we should be describing this sort of work against all our 10 big ambitions, really. So I do commend the strategy, and I think for all of us, I think it comes back to that thing. Let's all understand that this is about every intervention that we have and making sure that all sectors are able to provide the right support or to signpost people, because the pressure on this is going to get worse rather than better in the short term.
Thanks, Rob. Can I bring in Sean and then Susan?
Yeah, thanks, Chair. Just to reinforce Rob's comments, in giving a practical illustration, Jess and our Wakefield Place lead, Steve Turnbull, gave a presentation, if you remember, Jess, at the Wakefield Health and Wellbeing Board in January. And I was pleased to see Stan in the forward of the report write his piece there, because Stan and his colleagues in the voluntary and community sector in Wakefield remind us consistently that they're in touch on a daily basis with many vulnerable people who are very much the way Rob described there, and can provide early warning on need and support. And
I've just seen you up here. Thank you.
We made a conscious decision in the Mental Health Alliance in Wakefield to significantly increase our support to the voluntary and community sector to perform that role, not to expect they're a gatekeeper, but to recognise their valuable role in daily contact with members of the community who may feel vulnerable in this context. So really welcome this and fully support the actions that are described in the report.
Thank you, Sean. Susan.
Thank you. Yeah, it'd just be interesting to see a little bit more of the data. It says the data's not quite as good as it should be, is what you're saying, I think. And obviously we've struggled a bit during the pandemic to get ethnicity data around the deaths, and people keep asking me, oh, you know, is that a Black, Asian, minority ethnic community, have they got more deaths than others? And the answer is always, well, there's nothing recorded on death certificates. And I dare say this is the same problem, is it, that we don't really have good protected characteristic data of people who die by suicide, because you know, if we rely on death certificates, they're just going to give us that. So you know, I don't often see Bradford at the right end of a league table, and I wouldn't mind understanding a little bit about what that is about us that makes us below the national average. I'm very pleased it does, to be honest, and I hear about it when there's a suicide in Bradford. It's such a big thing and it affects all of us. I would like to know a bit more about the data, about why, what makes a difference. I think the other thing I'd just like to say as well is that guy in that video, of course, it was a letter that really also sent his wife to commit suicide, and I think there's something about all of us to look at our communications, isn't there, and about how they land with people who are in a vulnerable position, and that's all organisations just think about that. And it's quite a responsibility for all of us, isn't it, I'm afraid, but we need to be cited on that.
Thanks, Susan. Go to Peter Davis next.
Thank you. I'm going to pick up where Rob was talking and about suicide, and that some of the people who we meet who commit suicide have a mental health history, but a good half of them don't. And trying to work out those, just from my own experience, I think it's something to do with where there is an acute loss of dignity or self-image that can catch people. And I don't know if we are good as either as individual professionals or indeed just as a network of people in a society at picking up people who've had an acute loss of dignity and doing something where we go, even if it's just as simple as saying, you need a cup of tea, come and have a conversation. But I don't quite know how we can do that. But I sense there's something in this sudden loss of dignity, which so certainly a couple of cases I've seen where that was the actual issue. Or sorry, it was the final trigger. There had been other stuff going on for them before that.
Thank you, Peter. Kathy.
Thank you very much for this strategy, colleagues, and I really love the way it's been presented, both by sharing stories from real people as well as being really constructive in the outputs and the outcomes you're looking for. And I saw early thinking on this late last year when I was part of the Mental Health Provider Collaborative, so it's a really good piece of work. And I was meeting with local authority leaders earlier today who were saying, how do we track progress? So I think you've outlined it very well, and we just welcome hearing that as the work develops. I've got a few questions really, and this is an area of work I'm really interested in and passionate about. But one is, who are your partners of priority at the moment, and particularly the partners that you haven't quite reached? Again, my point earlier, this is a very influential group of people. Can we help you meet with the right people? Is the money working as well? Is the investment and contracts coming through, helping you both work on responding and supporting people like Steve, as well as working on the prevention element of that as well? And particularly, I think we need a more dynamic and innovative way we're going to reach younger audiences. And then I think there's something around, there's a number of things. Your point, Susan, on the letter, that Steve had a very transactional experience, and how can we share best practice where people are not thinking and approaching it in a transactional way? And then also more longer term, your point, Jess, that you've made, and I've been in a meeting with you before when you've talked about this, about the causes of unemployment, which is Rob's point on recession, and what broader medium to long term work can we do, which is another point of our partnership, as well as looking at economic development and tackling unemployment. So I have a lot of questions there, and just if you want to meet another time, I'd happy to, but I think there's something about the priorities, and then what can this group do to help influence, whether it's money or partnerships or different ways of working.
Thank you, Kathy. I've 3 more people indicated on this. I don't want to cut short what's obviously a really important sensitive item, but just aware how many more items we have on the agenda as well, so people can pull things together as we go through. That'd be really helpful. Fiona, you're next. Right, I think Fiona was having problems with her connection. So yeah, Kim, do you want to respond to Kathy, and then I'll have another go?
I thought I would respond to Kathy, because if you can rely on me for a frank answer to that, Kathy, and the answer is no, the money isn't working, and no, we haven't got the right profile for this. So you know, and that's part of, I guess, the ask to this is how, you know, with all the competing priorities that we have in our system, both at a strategic level and at an operational frontline staff level, how does this compete? I think there's 2 things there. In, you know, it's almost similar to some of those conversations about, you know, like that was in the inclusion. This is everybody's business, but how do you, if you have a group over there working on suicide prevention, there is a little bit of a danger that everybody else thinks, oh, it's going on over there. You know, and as somebody who's sat on the wellbeing board, you know, for a while, you know, maybe we will have an item that comes to the wellbeing board, or we'll see it in some of the data, but you know, it's not something that's embedded or necessarily got the, you know, in my mind, you know, the right profile. In terms of the investment, I think, you know, probably not everybody could say, but I'm sure everyone would agree that the decimation of public health funding has over the years contributed to there being very little investment in this area. So I recognise that local authorities have to make a judgment about investment in public health funding. And this is suicide prevention is therefore competing with a million other things. So actually, I think the investment is very, very patchy, and how, you know, whether that's something that could be looked at across the board, I think is something really important. So, you know, it's great to hear you asking those questions, Kathy, and others, because perhaps we can pick that up, you know, going forward in terms of addressing that.
Thank you, Kim. Sarah?
Thank you, Chair. Mine was coming back in as well, basically on Kathy's point and on Councillor Hinchcliffe's point as well around the data. So just really quickly, Jess has done some fabulous work, as is reflected in the strategy, with our public health colleagues on the real-time surveillance data. So the data we're getting will be better shortly on the suicide prevention work. So things like ethnicity and other wider factors will be included in there, which will allow us to be much more targeted. So I guess the data and the intelligence takes us so far in terms of where to look, couple that with the insight on what what we can do about it. I think that's really where the key to targeting some of the action once across the system will be. And again, in terms of investment, if you ask the question, Kathy, we'll come in with the answer similar to what Kim said. I think similar to the work we do on wider inequalities, investing in those seams between service, statutory and community, investing in that space, I think, is again where we could make some real progress on this agenda. So just a couple of reflections on those points, but we'll be really keen when we can to come and share some of that, the data from our real-time surveillance as well when we're able to.
Thanks, Sarah. Rob.
Just the, I guess just the last couple of points on this. I think we've got an opportunity in the planning round to think about the investments here, and we should do so. If this is a bigger killer than cancer, road traffic accidents, COVID, in that age group and in younger people, when we have to give it the priority that it deserves, would be the obvious point. And just a point which I feel I have to raise, which is there's a point about language that personally I would never use the phrase committed suicide. It's a hangover from when it was either a crime against God or a crime under the law, and it's no longer a crime under the law. But the stigma attached to suicide, and as someone bereaved by suicide, the stigma attached to it, and the shame that people feel is such that the use of language really matters. So if we all instead said that people died by suicide or took their own lives, that would be substantial improvement, I think.
Thanks, Rob. Jessica, final comment.
Yeah, just to wrap up, really, I think it's really important to emphasise the amount of collaborative work we've done on this programme over the last 12 months in terms of working right across the system, but beyond as well with the police, criminal justice colleagues. I think there's a lot of suicide prevention work happening, particularly on the wider determinants of health and beyond, through the voluntary sector and in communities. A lot of that is really flimsily funded, unsustainably funded, if at all. So actually, suicide prevention will happen in our communities as well as in our places of work. I think it's really important as a system we take that into consideration. We've got loads of buy-in from the VCS. We've got loads of, I haven't explained all the structures, but that's one of the things that I've worked really, really hard on, is that kind of collaboration through public health. And so the sort of the structures are there, the evidence is there, the investment, as Kim said, is probably lacking. That's my feelings anyway. So yeah, thank you again for giving me the opportunity to talk.
Thank you. So I think it's very clear from that debate that we're happy to endorse the strategy, and people are very keen to take on board the learning from it. So thank you for that very powerful presentation. Colleagues, I noticed I missed any plans for a comfort break halfway through, and we're now just gone 4 and we have 5 items left. Do people just want to carry straight on, or is anybody desperate for a break? Right, nobody's saying they are. So I have a can somewhere. Sorry, I just clicked on the wrong thing. Ian, yes, sorry.
Yeah, I was just going to, I mean, we're not going to get through the 5 items in the next 55 minutes. So I guess it's whether we want to take written comments maybe on the last 2, the item on the people plan and the 5-year strategy. The one's an update from last time, one's some work we're about to embark on, and focus on the first 3. I don't know what other folk think. I mean, we're really keen to discuss them all, but we're not going to get through them by 5, are we?
Yeah, thanks, Ian. That seems quite sensible. People okay with that? And can I ask people on the first 3 items to obviously if possible to sort of keep presentations fairly short, 2 or 3 minutes, so in case there's time for things. Is that okay? Okay, so let's crack on with the planning priorities, and I think that's Anthony.
Yes, thanks, Councillor Swift. Hello, everyone. I'm Anthony Keeley. I'm the NHS England and NHS Improvement Locality Director for West Yorkshire, and I can be very brief on this one as well. This is very much an update on the process that we're going through to set our priorities as a partnership for the coming year and the planning that underpins the work that needs to take place to achieve those priorities. And you've got quite a lengthy paper. I did have some summary slides, but in view of the time, I'll just give you the very briefest headlines instead. So some of you will recall in each of the last 2 years, I've been the equivalent meetings of this partnership board giving similar updates around how we were about to plan for the years ahead. And of course, the plans that we set in the last 2 years were in each case kind of overtaken by the impact of the pandemic. And we had to adjust a lot of what we were doing, to respond to the needs of the pandemic in all sectors of the partnership, whether that was hospitals, primary care, social care, the voluntary sector. I think it just feels as if we're at quite an important transition stage now, though, as we emerge from what hopefully we'll look back on and see as the acute phase of the pandemic. I wouldn't want to suggest it's over and behind us. It's not by any means, but it does feel as if, as a result of the vaccination programme and other changes, that we're now in a much more sustainable position to plan to move beyond the main focus of what we're doing being on pandemic response. So the paper really just highlights the things that we're keen to focus on, which are based initially on our 5-year strategic plan and the big ambitions that fall out of that. Also on the sort of the significant priorities around social care, which derive from the social care white paper that the government published before Christmas. And on the NHS side of the partnership, on the 10 priorities for the NHS that were set out again before Christmas by NHS England. So as usual, we've got a very inclusive, place-based, bottom-up approach to developing our operational plans around those priorities. And what we have is a process which will bring the partners in each place together to produce a draft plan. Those will be aggregated into a West Yorkshire plan, and that will encompass our shared collective priorities. There will, of course, be a big focus in our plans around some of the big challenges we face as we do emerge from the pandemic, particularly around tackling waiting time for services and people's ability to access a whole range of services. And also, of course, our investment plans and priorities as well. And a lot of the mechanics of the system are changing, particularly in financial terms. So the NHS is returning to a much more familiar pattern of financial ways of working as we move away from the very special COVID-related allocations and transactional processes we've had. So the paper sets out all the work we're doing around addressing those challenges. We've got a process underway which will allow us to produce a draft ICS plan by the 17th of March, and then following feedback and discussion, a final version of that by the end of April. So we just really wanted to give the board some assurance of the process that's underway to demonstrate that it's an inclusive, a bottom-up, a place-based process, and it's addressing our collective local priorities as well as national requirements. So I think that's probably it, Chair, in terms of the headlines of the paper. If there's time, happy to take any questions on it.
Thank you. Yeah, no, that's fine. So any questions or immediate comments on paper? Yes, Diane.
Thanks, Chair. I was really impressed with the paper, and I think it was very clear in terms of the top 10 priorities. I guess an observation for me was that within those, I think it was 17H, sorry, I'm looking at the screen so I haven't got the paper in front of me, but it talks about digital and using digital technologies to help with some of the other things that are there. I guess my question, Anthony, would be, is that not an enabler? So for me, really, and I'm sure it is not ordered in terms of priority of those 10, but I'm really interested to hear what's going on the digital front, because for me, that does enable many others of those tends to happen, and if we've got any chance of resolving many of those, digital has to play a part. And I know at our board we are really interested and focused on what we can do from a digital perspective. So any learning that we can get from the partnership or any input we can have, the more that we learn together on this, the better. So I get just interested in where you are with it and what we can all do to benefit each other.
Thanks, Diane. Anthony, anything to add to that one?
Yes, thanks, Chair, and thanks, Diana. Really great point to make, I think. And you're right, I would agree that sort of digital transformation is an enabler of some of the other priorities, along with, I would suggest, some of the other things in that list of priorities, particularly around the workforce and some of the, for example, some of the things like the capital developments we need to make in terms of our estate and facilities. So yes, I think we have some real opportunities with some of the national funding that's being made available and the focus of work that's going on around digital transformation to make us, I think, a bit of a step change in how we provide services and support people across West Yorkshire. So agree that it's going to be really important to make sure we're focusing on doing that together with all sectors of the partnership, not just the NHS or any other sector. So we'll pick that up with colleagues in the digital programme to make sure that we've got a fully inclusive approach to doing that. So thank you.
Thank you.
Thank you. Susan?
Thanks. I'm just looking at those NHS planning priorities. They don't really reflect the new government's new levelling up white paper priorities, one of which is more similar to ours, actually, which is about the healthy life expectancy. And I just think it just shows government is not joined up, and I think we have a role to play, haven't we, in trying to get them to join up with each other, because I don't think this reflects where the government are actually on levelling up. And I think we should probably, if we could put that challenge back to them, I think it'd be helpful. And also it doesn't mention about children's health really specifically, and I think that's an oversight really. And I think that's been a problem for us here in Bradford for some time. But I do think, you know, when you've got a national framework that doesn't really doesn't nail that item, then I think that is an issue.
Thanks. Rob?
Yeah, I think so. Partly in response to Councillor Hinchcliffe's point, you know, we've sorry if I've frozen.
No, carry on.
If you look at the priorities that we had during the Omicron surge, children was the additional one we put in over and above the national ones, because it often gets a bit lost in the integration piece by not being explicit enough. And that lends itself to, I think, the way we've got to think about planning over the next year and what the expectations of us might be from the centre and elsewhere. So there are a number of things where I think there'll be a significant amount of scrutiny in the very short term about what we're saying we're going to achieve. And Julian talked about this earlier around elective recovery. So the expectation that nobody will wait more than 2 years, let's not use weeks, let's say it like it's wait more than 2 years by the 1st July. So there'll be a lot of scrutiny on that. And I think there'll continue to be significant scrutiny, more scrutiny on the money than there has been in the very short term. There will be scrutiny on the other priorities as well, but I think we should continue to see those as one element of our overall plan. And the broader elements, including things like children, the wider determinants, you know, our focus on the green agenda, etc., have got to be part of our planning processes, because the NHS priorities are just one chapter in the book, aren't they? That's what we've always said. So we'll try and do that, but let's make sure that collectively, if there are any big gaps, we keep making sure that they're included. And if there are certain points of emphasis that we want to make sure are clear, then we pick those up quickly.
Okay, thanks, Rob. Susan, is that your hand still up? Or you can...
Sorry, yeah, sorry, Chair, I'll be quick. So if you're going to have to measure, and I accept these are national things and it's not anybody's fault here, but if you have to measure elective waiting times, can we also make it a self-discipline of West Yorkshire to also measure how long people have to wait, how long children have to wait for CAMS, for example? So I don't think we should look at waiting lists across need and not just for one cohort. That's really quite important, just to show ourselves that.
Exactly right, and we do have to do that, and I think we should prioritise that, given the shocking statistics around children's mental health. You know, going from 1 in 9 children affected to 1 in 6. You know, we know that there's already been an increase in morbidity, and it's been exacerbated by the pandemic. So there's work to do. I think it points Councillor Hinchcliffe to places and place-based planning where local health and wellbeing boards are satisfied that the plans address the real issues affecting local people's needs. And I think the other really positive thing that NHS England have done, I think prompted in part at least by the work that Philip and Owen did at Calderdale, is to say that you've got to look at deprivation and ethnicity when it comes to tackling waiting, so that we don't have greater inequalities. So even when we're looking at something which you might think is mainstream national policy, I think there's a lot more understanding and interest now in diversity and deprivation, and the fact that we have to address those things. So I think that's really welcome. And as Julian alluded to earlier, waiting is a bit of a chronic condition for some people now. You know, whilst they're waiting, they're anxious. Whilst they're waiting, they're unable to function. They might not be able to work. So it's in all our interests that we address it.
Thanks, Rob. Anthony, I'm not sure if there's anything you want to come back on.
Well, just to conclude, I think that's a really helpful point from Councillor Hinchcliffe, to really make sure we've got a focus on children and young people, and we will take that into the process and you know, measure the things that are important for that group. And it's not all about CAMS, of course. That we need to look at things like waiting for assessment for special educational needs and disability, and autism assessments, and a whole range of things. So we'll make sure there's a broad focus on children and young people's issues through this process. So yeah, thanks for that. We'll take that away.
Okay, thank you, and we'll endorse that direction of travel with those comments. So I'll move on to the next one, which is constitution and governance. Stephen.
Hi, afternoon everyone. I'm Stephen Gregg. I'm the governance lead for the partnership, and I've been working with partners on the ICS governance working group on the co-production of the governance arrangements over the last few months. The report provides an update on the constitution and our wider arrangements. I won't go through it in detail. I'll just summarise, I think, some of the key points. But I think it's worth saying at the start that, I mean, during the course of today's meeting, we've heard some really powerful messages, and I think it's important that these arrangements we're talking about, they aren't governance for its own sake. They're designed to try and make sure that we've got inclusive, transparent decision-making arrangements that enable decisions to be made close to local communities that can really make a difference. So absolutely clear that unless our governance arrangements enable us to do that, we need to rethink. So in terms of involvement on the constitution, we ran a 2-month process from November to January, and we had some really helpful feedback from partners, members of the public, overview and scrutiny committees, and we've used those to both refine some of the detailed wording in the constitution and also think about the supporting arrangements that sit beneath that constitution. It is important to note that this is still work in progress. The current version is based on the 3rd version of the National Model Constitution, and there's another version to come at the end of March, which will feature some of the changes in the regulations. So it is still a bit of a movable feast, but I'm hoping that the changes won't be too great in future iterations. So you've got a summary of the feedback from the involvement process at Annex 1 and then the amended constitution at Annex 2. We've tried to set out a kind of you said we did in relation to how we've taken comments into account. Just to highlight some of the main drafting changes, we've put some new wording in around clarifying our objectives around, for example, an explicit commitment to a comprehensive health service for our residents. There's changes around board composition, around strengthening independent challenge, making sure that the people agenda is represented with a seat on the board, clarifying the role of board partner members, that role of bringing a perspective of their sector or their place, not acting as a representative or delegate for their organisation, and building in formal and rigorous annual evaluation of the board and its governance arrangements. We also had quite a lot of other wider comments, particularly around patient and public engagement, both in terms of formal decision making and our wider arrangements. So again, I'd highlight that all our formal ICB committees will be held in public, and in terms of our wider arrangements, we're developing proposals for a citizens panel to make sure we've got that right across the system. And that kind of broad feedback from involvement also highlighted the need to make sure that in our arrangements we really do tell our West Yorkshire story. Difficult to tell that in a document like the Constitution, which is very much bound by the national model. But in our handbook, we've got the opportunity to set out the wider partnership collaborative arrangements that inform ICB decision making. So in particular, the role of health and wellbeing boards and the partnership board in setting strategy, the role of provider collaboratives in decision making and partnership working at both place and system level, and how clinical and professional leadership feeds into those arrangements. So we're developing a set of case studies which will include in the governance handbook, which will cover decision making both across places and across ICS footprints, but hopefully will, if you like, bring to light the governance arrangement and make it clear how we want to work in West Yorkshire around that. It's already been referred in terms of making progress. We've already made appointments to a number of executive roles, and recruitment to the independent non-executive member roles is in progress. There is a further delay in relation to the appointment process for partner members. Those appointments can't be made until after the partner member regulations become law, and we now understand that may not be until May, so there will be an enforced delay before we can confirm our arrangements for partner members on the board. Just touching a bit further on the governance handbook, obviously central to our model is delegation to place. Each place is establishing a place-based committee to take on decisions about ICB functions and resources, and you'll be aware that recruitment is underway to independent roles on those committees. In support of West Yorkshire level working, we're proposing some committees to support the ICB board, and at para 15 we set out a draft proposal about what that committee structure looks like. Throughout this, we have got to have a mind to making sure that arrangements are as streamlined and as efficient as they can be. We're proposing a quarterly cycle initially, though we recognise that in the early stages some groups may need to meet more frequently. And it's also, I think, worth remembering that some things like audit and remuneration under current arrangements are done 5 times across places. Under the new arrangement, we'll be doing once under the statutory ICB. So there are opportunities for streamlining that we need to take. In terms of wider ICS governance, the ICP, the Integrated Care Partnership, essentially the current partnership board, as you know, will be formally established as a joint committee of the ICB and local authorities, so we won't be able to formally establish that until the ICB has established itself in July. But we are liaising with local authority governance colleagues to make sure that we've got in place the right arrangements to make sure we can formally establish the ICP once the ICB itself has been established. Until that time, it's proposed that the current partnership board continues to meet and operate in its current form. And obviously the ICB committee structure is only one part of our partnership decision making infrastructure, and we propose to continue, for example, with our partnership leadership days and continue with existing collaborative forums, for example, clinical forum and the finance forum. The delay in the Health and Care Act clearly provides us an opportunity to test our arrangements during a period of shadow operation between April and June. We've already started to formally set up some of those arrangements. So, for example, we've had a shadow remuneration and nomination committee established to make recommendations on board level pay, and we've got trust, NEDs and CCG lane members sitting on that shadow committee. And as recruitment to other ICB board role progresses, we'll be in a position by April 22 to start to establish our shadow board and committees, with some exceptions, as I say, around partner members. All of the new governance arrangements, we recognise we think represent evolution rather than revolution. We're trying to keep with the principles and collaborative ways of working that we've established. So it's important that they build on those partnership values and principles. And key to that, I think, is that we build in formal review, both of the shadow phase and the early months of statutory operation. And we built in some formal review into the Constitution so that we're absolutely clear 12 months in that whether it's the board or the supporting governance arrangements are fit for purpose. So in terms of the timeline, we plan to present a final draft of the Constitution to a shadow ICB board meeting in April. We're required to report the draft Constitution to NHS England for comment and agreement, and then in June we'll bring back the final draft and the governance handbook to the partnership board prior to the Constitution coming into being with the creation of the ICB on the 1st of July. So, let's say, welcome comments on what we've heard from stakeholder involvement and how we reflected that in the draft documents. Note that the Constitution is still in draft, so really welcome further comments and suggestions for improvement. And note that key piece of work to develop their governance handbook, in particular case studies, to make sure that the role of key components of our system, health and wellbeing boards, provider collaboratives, are part and parcel of the wider documentation that we're putting together.
Thank you, Stephen. Any immediate questions or comments on that? Yeah, Kathy.
So I wanted to thank anyone who's taken the time to go through the Constitution. I'm really pleased that we had such a variety of people come back to us, and some people shared general thoughts or concerns and other people went through it line by line. So thank you, and thanks to Stephen for navigating all this, matching the national guidance to what we want as a West Yorkshire partnership. So I think that's important. There's a couple of things I suppose I wanted to draw out, which is one around the citizens panel, which Healthwatch are grateful to you for your help, but also feedback we've received from local authority colleagues on how we make sure it complements and works with their representation and their work with their constituents as well. And I know my colleague Karen Coleman's here today, who's doing so much on our work on participation and making sure citizens' voices are heard. But this is a piece of work in trying to embed citizens' voices, which is also complemented by the non-exec role that I am working to recruit for at the moment with colleagues, which will have a remit for citizens and future generations. So that was one point. And then place committee chairs, as Stephen said, we've started recruitment last week for Kirk Lees. I'm really grateful to each place for inviting me in to be part of those discussions, shortlisting and the recruitment process. And by the end of next week, I think we will have then gone through the recruitment for all place committees as well. And I suppose another point as well is we've received feedback, particularly from NHS chairs, to make sure provide a collaborative. So those specialist services, and particularly we have, as you appreciate, Wyatt for acute. We have our mental health, learning disabilities and autism's collaborative, and we also have an emerging community services one as well. So they are better referenced in the Constitution, and also you can see that in the ICB membership as well. So just some points, Tim, I wanted to make. But thank you very much for everyone. Sometimes people feel governance is a bit boring, but I'm pleased that people have been active and enthusiastic about it.
Thank you, Kathy. Philip.
I just wanted to say thank you to Stephen and all his colleagues, because I've been involved with this all the way through. For me, it reflects a different way of doing things. It's almost designed from place, looking back towards the institutions rather from the institutions looking towards place. We've discussed it as a board, with all the non-executive directors. And I feel the real emphasis on place, and the leaders and the chairs group, there was an emphasis about harnessing local energy, especially local councillors. And if I could underline that, then that's what I would say strongly to you, that's what's said. Because that, if you read some of the other papers, builds around the primary care networks. I won't say anything else because I'm sure Susan can say it more eloquently than me.
Thank you. Simon.
Thank you, Councillor Swift. Stephen, it was just a note from the Basic Quality Network just to acknowledge how easy and unique it's been in our system to ensure that the Race Quality Network has a seat at the table in the ICB board. When we've talked to other networks and other systems, it's not happening elsewhere. So it was just a point to thank you that that's been included, and an ask to ensure that this sort of model runs across our place structures as well. So thank you.
Thank you. Susan?
I'm sorry I'm so predictable, but yes, it's exactly what I was going to say, that backbench counsellors are really good value in terms of connecting into communities, and if you can get them involved in community partnerships and local health working, they'll be able to navigate loads of issues, so get connected with loads of people, and I cannot stress out what good value for money counsellors are, so please do involve them. Don't create something new, as say in citizens panel. That is what your counsellors are there for, so do use them and use us leaders to make sure they are involved as well, and we'll get them involved.
Okay, thank you. So a few things to take back there. Stephen, anything you want to add?
No, not really. I think the only thing to say is really it is still in draft. So conscious we took it to chairs and leaders last week and raised some important points just to reflect in the final version of the draft to make sure, for example, that we're as inclusive as we need to be in terms of reference to all the partners in the introduction. So had some useful further comments from that. So if there is anything that you spot within the documents that you think that's not right or it's not quite phrased right, it's not too late to send that through, and we'll pick it up in the final draft.
Thanks, Kathy.
Just a point on the appointment process for partners to the ICB, because we're sort of starting to come together. At one point it was Rob and I just as the ICB founding members. We now have our place leads, we've had our executives particularly formally announced today. So Stephen, what do you think the time frame will be for those, as well as we've got to submit the next version of the Constitution? I thought, Tim, it might be helpful for colleagues to know.
In terms of the partner members, we've literally had an update from NHS England earlier today that suggests that we're not going to be able to start the appointment process until the 6th of May. So that is slightly later than we'd originally led to believe we would be able to start that process. It had been suggested we could start in the end of March and look to get the process underway in April, but we've had. I think the timescales that have come out today are still indicative, but it is now suggested that it will be May before we can actually press the start button on partner member appointments, unfortunately.
Okay, thank you.
Thank you. Okay, no other comments on that, so I'm taking it we're happy with the suggested notes and actions with the addition of the comments we've made. So the green plan. This is Frank and Hawaran.
Thank you very much, Councillor Swift. For those of you that don't know me, my name's Frank Swinton. I'm both a consultant anaesthetist at Airedale Hospital and the climate change lead for the ICS. And I've got 2 or 3 things to tell you about today. But first of all, I'd like my colleague Hawaran to introduce herself while I start sharing my screen.
Hi everybody, I'm Hawaran Hussain. I'm the Senior Net Zero Programme Manager employed by NHSE, place-based within West Yorkshire with yourselves.
Thanks, Hawaran. So I've been here all afternoon, and I'm really struck by lots and lots of overlap between the climate change work and lots of the other stuff that's happening, the workforce stuff, the anti-racism, the inclusion stuff. And what's really struck me is that in lots of these dimensions, we need a paradigm shift in order to avoid a very frightening future. I think that we are national leaders in the ICS. The climate change team is a national leader, and people are looking to us for guidance. There's talk about resource, and more about that in a moment. There's talk about the importance of data, and specifically to Anthony's paper and Ian's paper. Thanks, Ian, for sacrificing and Joe for sacrificing your places so that we could talk about this. But what sprang to mind was a quote from Lord Victor Adebowale, who was the chair of the NHS Confederation, who came to our online climate and health conference in 2020, and he said, his words were, look, it's ridiculous to make a population health plan without taking climate change into account. So that's what we're bringing to you today. The climate change team, I hope you can see my screen. Hawaran, I can only see you. Are my slides showing?
It is showing.
Brilliant, thank you. So the climate change team has been in situ for about 2 years now. We've done a lot of work, a lot of network creation, a lot of sharing resource and sharing ideas and energy, a lot of engagement work. We've created an impact, got involved in the impact assessment tool, huge energy around green social prescribing, provided some training. We're doing some, as far as we know, globally leading work on the environmental impact of hospice and end-of-life care. We've created a website, we've hosted lunch and learn sessions that people have come to from all over the country, and we've written an NHS Green Plan. We're going to come on to that in a moment. I wanted to talk about our demand and our ambition. So at the moment, demand is massively outstripping our ability to deliver. And people are coming to us and they're saying, you know, what should we do? We understand that climate change is important. We guess that there's a healthcare angle, health and social care angle. What should we do? And so we've provided some training via the Centre for Sustainable Healthcare, but it's not really able to keep up with demand. We've got a plan to create some more networks, particularly, as you can see there, social care and the VCS, but also place-based networks. We would love to do more on travel, more on food, more data collection and presentation. And increasingly so, in the last month, I've had several requests from the NHS Leadership Academy to get involved in training their EGA courses and the graduate management training scheme. So there's a lot of demand on our time. So our asks from you are that please can climate change or sustainability, environmental sustainability, be in the ICS strategy going forwards. The Greener NHS, and this is NHS centric, but the Greener NHS has an ask that every board in the NHS has a named net zero lead. And we ask that that's extended to every board in the ICS, including the ICS board. There is currently not a named ICS board member highlighted for sustainability. I think that right now, today, we've got work for 3 more whole-time equivalents. There are currently 2 whole-time equivalents in the team. Hawaran is one of them, and she's funded by NHSEI centrally. I think there's right now, today, there's work for 3 more full-time equivalents, and that's not without trying to find work. And finally, the Green Plan, which you've had in your papers, is, as I said, NHS centric. We are in the process of refreshing our strategy for the whole of the ICS across the whole of health and social care. But this Green Plan is a specific ask from the Greener NHS central team, which should be board approved and submitted to them by the end of March. So we wanted to get it to you now, ready to take comments so that we can make any amendments and send it on to them by the end of the month. I'm going to stop there and hopefully give you a few more minutes back, but very happy to take questions.
Thank you very much, Frank. I think you probably preempted one of the questions and comments you're going to get about the extent to which it's NHS centric, and obviously I reflect that partly reflects the sort of top down way that NHS England have made their requests. But do people have any immediate questions or comments? I'll take what you said, that if we don't pick things up today, there is also this is still an opportunity to feed things back to you as well, Frank. Yes, Anthony.
Yeah, just a really quick point. Really important work and really welcome this. And I think obviously in Leeds at our Health and Wellbeing Board, we've had a health and care climate commitment for a couple of years now, so it definitely would be worth linking up there. The capacity on this issue, I think, across health and care, like you've mentioned, is a real challenge, but there's probably quite a lot we can do together. Local authorities, you know, us in Leeds and colleagues elsewhere have got climate leads. I'm sure you've had conversations with a number of those. But a real opportunity, I think, for a joint approach, because I think particularly in the acute sector, the NHS has done some really strong, really positive work, but that's been done in close partnership with local government for obvious reasons. So yeah, just I guess you know, some real opportunities to really deepen the approach and go further faster, which is absolutely necessary.
Thank you. Len Richards.
Yeah,
sorry. Yeah, carry on. Yeah.
Thank you, Councillor Swift, and thanks, Frank, for the report, which I think is a really good report, really positive, and sets out the ambition of the ICS. I think the issue of resourcing is a tricky one, because I do think in line with what Anthony's just come in, it's how do we balance resources across place, whereby we'll be multi-agency, linking in with local authorities, linking in with the infrastructure of the place, and then build up to the ICS. And I'd like to, as you know, Frank, I'm leading on behalf of WIAT around this agenda, and I'd like to really sit down with you and think through how we can balance that resourcing, because if we look at it in the round, there will be quite a lot of expertise and a lot of resource being focused on this. It's how do we bring it together to maximum effect. But a great report, and endorse it fully. Thank you.
Thank you, Len. Rob. Yeah.
A similar point really, but I know that a number of organisations have got a green plan because it was a requirement, and then they have a broader sustainability strategy, which some organisations are yet to complete, but I've got the ambition to do so. And then we've got councils and organisations who've declared a climate emergency. So what I'm sort of reaching for is us to bring all of that together in a way which allows us to apply the maximum capacity to the problem in front of us. And it is in front of us, Frank, isn't it? Because, you know, for those of us looking at the third time we've had once in a generation floods, Tim, in Calderdale in a decade, you know, you can see that this isn't some future threat, it's here now, and we need to definitely do something about it now. So my maybe Len can lead this with a couple of others, is just to do a quick bit of work about how we're bringing together the council climate emergency statements and support, how we're bringing together the wider sustainability strategies and the green plan to make the biggest difference we can.
Thanks, Rob. Susan?
Yeah, I'm not, Councillor Venner has not been able to get back on, but I know she did want to just make the point, I think, that it's very not just NHS, but it's very hospital focused, and whether the primary care also needed to have more emphasis in there. It's just a Councillor Venner point rather than Susan.
Yeah, I am here now.
Sorry,
I've missed most of the meeting. Teams just keeps repeatedly throwing me out. And I've had IT help, which has been of limited use, but anyway, I'm here now. Yes, good. I felt the paper wasn't, I felt it wasn't very partnership focused, really, particularly given public health is in council, and I also felt that it wasn't, it was very hospital focused. So in the final recommendation and the summary, there's a couple that are about public health, but actually it's predominantly about hospitals and buildings and hospital catering. So I thought there wasn't enough emphasis on public health, on primary care, and also I thought it seemed really light on references to poverty in terms of actually things like air quality and access to green space. That the pandemic has really kind of exacerbated and highlighted inequalities that already existed. So yeah, those were my comments, which I've managed to make before I get through now. So I'm very pleased.
Thanks, Fiona. Frank, I know you'd already indicated. Do you want to come back on some of those points?
Yeah, thank you very much. So I'll take Rob first. The ask for resource is absolutely to convene, is to just to network, because we can't manage that at the moment. So it's not that we're looking to do the work, we're looking to bring the people together. Even that's a struggle at the moment. And to move on to Councillor Venner, I absolutely agree with everything that you've said. You're right. The paper that we've submitted to you is in response to the guidance given to us by the national team. And we've been saying for a long time that there's more to it than carbon in hospitals. They are getting there. I was on a meeting this morning about national meeting about primary care green plans to go alongside the green plan that you've seen. That's not currently an ask from the national team, but I can tell you that our primary care network is already in the process of writing its own green plan. So I agree with your comments about inequalities in green space. All of that is really profoundly embedded in the wider ICS sustainability strategy. But the reason it's not in this document is because that isn't the focus of the ask from the national team.
Thanks, Frank. Sarah, yeah.
Yeah, thank you. And as part of our wide improving population health programme, as you've seen today, in terms of the agenda items is touched on, climate change falls in our team. And I just wanted to draw Partnership Board's attention to the ask of one of the asks that Frank made in the cover paper, which was around whether we could bring back that whole sustainability piece maybe to a future meeting. So I think that's hopefully the way it's heading, but that there's that offer from the team that actually we could pull these elements together and bring back the full picture essentially. Believe it or not, Frank and Warren have been kind of pushing the boundaries in terms of what's been asked nationally and broadened it out with the response to this green plan, but we'd really like to kind of reflect everything that's going on in West Yorkshire to meet our partnership ambition alongside, you know, the specific NHS requirements. So that's an offer, I guess, from on behalf of Frank and Hawar and our team to bring something broader back in the future.
Okay, that's something we can pick up and like to sort of see how that links with the combined authority work as well. Rob.
So I think what I'm hearing is there's agreement to, if we can do a piece of work that draws together all of the plans that are going on, all the capacity that's going on, and try and reshape it into something that's going to be coherent and make the biggest difference possible, then we should do that piece of work. And if we've got a bit of resource for it, that would be really helpful. So I think there's positive support for that. I think the only other point I want to make is that we should, whilst we recognise this is focused on carbon in hospitals and anaesthetic gases and things like that, the numbers and the improvement made on those things is fantastic. You know, it shows that you can make a difference and you can do things that make a difference. And in this space, it often feels a bit like, you know, we're all wringing our hands and we're wondering if we're ever going to be able to make progress. But you can make progress. And we have, if we make a step change. And what we're doing here, I think, is collectively saying, how do you come together to make the next big step change that we have to, if we're really going to continue to make the kind of improvements that we've made so far. So I just want to say thanks to Frank and the team for bringing this stuff. And it sounds to me like we've got a commitment to go broader and bigger on this agenda.
Okay, I think that's fair. Okay, thank you very much. I'll echo those thanks, Frank, for the report and the work. Right. That leaves us then with, I think, the two items that Ian, you were suggested we need to find different ways of handling and reflect on. I apologise for the people about the People's Plan, first of all, who've no doubt sat and been patiently and largely run out of time. I don't know if there's any points anybody wants to say immediately about this, but I do take, I think, I've lost track of the chat, so I do take the comment in the chat that says we really need to make sure this is an earlier agenda item on a future meeting, because this is pretty significant. But just that, Ian, have I remembered correctly what was said? Because I've kind of lost the plot slightly.
Yeah, that's right, Councillor Swift. That was Helen's comment. We brought the actual strategy in December, and we slightly ran out of time on it then. I think that Sarah and Joe might have left though in terms of picking up any points on that.
That's fine. Yeah.
I'm still here, Ian.
Oh, sorry.
Okay.
Was there anything that you wanted to pick up on that?
Not specifically, Ian, but if anyone's got any comments or any written feedback they want to give us, that'd be really good. I think we might be on the agenda for June as well, so anything useful that we can kind of build into coming back in June, that people either want to say or send us, that'd be really good.
Excellent. Yeah, good point. Rob? Yeah.
Well, let Sarah come in first, Chair.
Okay, Sarah. Yeah.
Thank you, Chair, and thank you, Rob. It's just to say that the actual people plan itself, which went out with the papers, is going to be launched later this month in the various formats, thanks to Karen's and the team's work there. So please look out for that. But and just to say, this will be my last time presenting to the board on the people agenda as I'm moving on. So thank you so much for all your support in the work up to date. And Joe will come to the next meeting with the progress. Thank you.
Okay, thank you so much, Sarah. Rob?
Just to say that there's, I think the people plan work. We could pick up some comments at the chairs and leaders reference group if we felt that was useful. And I think we've now appointed our full-time director of people who's due to start with us in June. We might ask her to sort of present some thoughts at the next meeting and progress with Joe on how we bring this to life and make the biggest difference we can. Finally, on this one, I think there's quite a bit of work going on nationally around a people plan. You might have seen the Secretary of State and others reference that in terms of health and care. And I know there's some work going on volunteering, and I was asked the other day, how do you get ICSs interested in volunteering and the voluntary sector? And I reinforced that volunteering and the voluntary sector are a fundamental part of our partnership, and also that volunteering is a key plank in the people plan. So I expect to see some national material emerging, and I think we're close enough to it to be consistent with it. We may even get some additional support from it. So in June, I think I'm looking forward to seeing the next phases of the plan and how we're going to bring it to life.
Thanks, Rob. Susan, same topic.
Yeah, just bearing in mind the inclusion work and the racism stuff we talked about earlier in the meeting, I just want to make sure that this properly reflects that work. So I'd like to see targets for us around more ethnic diversity in senior management, for example, in the next 4 years. So some KPIs about what we want to achieve, not just the programmes themselves. So if we can cover that in June, that'd be great.
Thanks. Yeah, I'm seeing some nods to that one, so we can pick that up. Okay, thank you. And then finally, we had the refresh of the 5-year strategy. And Ian, I mean, this paper is basically kicking off some work anyway, isn't it? I mean, just want to say how you suggest we take this forward.
Yep, thanks very much, Councillor Swift. Yeah, so there's two parts to the paper. The first part is a proposal for how we refresh the strategy over the next 12 months, recognising that we've got a pretty good strategy. It's got 10 big ambitions that we're all, supportive of and behind, but also recognising that the context in which we work is different following the pandemic, and so things like access to services have gone higher up the agenda in line with the conversations that we've had previously. So the first part of it is about a bit of approach and process for how we refresh that strategy, recognising it will be very much evolution from what we've got. The second part of the paper then is about how we develop a clearer delivery and improvement framework to support delivery of the strategy. And this is kind of very much in line with the suicide prevention paper we had earlier. Can we be clearer in terms of the actions at organisation level, neighbourhood level, place level, system level, to really give us confidence that this stuff is going to get delivered in a way that makes sense to us. can we have a financial strategy that fully supports the overall strategic ambitions of the partnership? Can we be clear about how we're going to use mutual accountability and peer review to oversee delivery of these things? And can we be clear about how things like the digital strategy, workforce strategy, estate strategy all fit together to support delivery of this? So we've done quite a lot on this anyway, but it's really just about tightening up how we oversee delivery and are confident of implementation of our agreed objectives, really. So there was those two parts to it. Happy to take any quick comments now, but we'll be doing quite a lot of engagement on this over the coming months. There'll be lots of opportunities in the future to feed in.
Thanks, and we had an initial stab at some of this with the leaders and health and wellbeing chairs earlier, and we'll pick that conversation up further, but very much about making sure the strategy is about delivering things and moving forward rather than simply rewriting discussions we've been through before. I think probably be how I clumsily summarize that conversation. Any immediate questions or comments for Ian on that? It's a useful way forward. So, okay, so thank you very much, everyone. I don't know, I'm assuming there are no items of any other business. Sorry, it turned a bit of a race towards the end there. Perhaps a dozen substantive items was a little ambitious, as it turned out, perhaps. But at least nobody can claim we had a thin and uninteresting agenda. So thank you very much, everybody, for your time and contributions today. As picked up already, the next meeting's in June. It seems scary to me that we've only just started this year and we're talking about meetings in June, but there you go. But thank you very much, everyone, and look forward to seeing you again at future meetings. Thank you.